So in this, the next following chapters and lectures, we're going to be discussing cerebrovascular as well as the intracranial anatomy. So we're going to both learn extracranial vessels that bring blood flow up to the brain, as well as the intracranial blood vessels that supply or circulate blood flow around the brain. So we're going to learn about the cerebral arterial system. So the cerebrovascular system, it supplies blood flow for the central nervous system. So the main thing being our brain. The blood supply to the brain is primarily through our carotid arteries. We're going to learn in a minute. We have a common carotid artery on each slide, which bifurcates or splits into our internal carotid artery and our external carotid artery. And we also have vertebral arteries, again, that branch off the subclavian that also supply blood flow to our brain as well. So we're going to learn about the extracranial carotids as well as the intracranial arteries. So that's going to be our circle of Willis. We're also going to learn about our cerebral hemodynamics. So in carotid or in cerebrovascular ultrasound, it's all about resistive indices and understanding resistive indices and what these changes in resistive indices indicate and mean. Because understanding, these changes in resistive indices and these changes in the waveforms will help you to identify the location of disease. So really our job as sonographers when we're doing cerebrovascular ultrasound is to try and pinpoint and locate, where disease could potentially be. Because remember, disease could potentially be intracranial, higher up, and we're not seeing it. Maybe perhaps due to patient body habits, we can't see a segment of the artery. Maybe a vessel's calcified, we can't see what's going on underneath that calcification. Perhaps it's down close near the origin, and just we can't see that low down in that patient's carotid, So there's a whole multitude of reasons why we may not be able to actually visualize, that stenotic lesion. But being able to, understand the changes of waveforms that we're seeing at that particular location where we're sampling, we were able to tell if the disease is either proximal to where we're sampling or distal to where we're sampling. So that's really like what the hardest part, for students learning this is just being able to grasp that notion as like, is this proximal? Is this waveform telling me that the disease is proximal to where I'm sampling, or is it distal to where I'm sampling? Is it farther up, or is it below where I'm sampling? Is it more proximal? So just remember when we're talking about cerebrovascular, proximal is going to be closer to the heart, distal further away from the heart, so up closer towards the brain. And also remember when we're talking about cerebrovascular, blood flow going to the brain, where brain is an organ, so it's going to be organ flow. So we should have low resistant blood flow. So you guys are going to get sick and tired of me here and saying low resistant, high resistant. We're also going to learn about how collateralization plays a role, particularly in the intracranial circulation with our circle of Willis. So some basic anatomy. So when we're talking about the extracranial carotid artery, so outside of the cranium, the vessels that we have are our common carotid artery, our internal carotid artery, external carotid artery, and the vertebral artery. So common carotid artery, again, on the right side, we have our common carotid artery. So that on the right side, we have our brachiocephalic, which branches into our common carotid and right subclavian on the right side. On the left side, the common carotid artery directly is a branch off our aortic arch. So that's that third branch of our aortic arch on the left side. As we move more distal up the common carotid artery on each side, it then bifurcates into our internal and external carotid arteries. External carotid arteries will start steering more towards the patient's face And the external carotid artery has many branches to it. And we're going to learn these branches in a minute. And they primarily feed the muscles of the face and the glands. The external carotid artery is considered higher resistance when compared to that internal carotid artery, because this is more supplying muscles. So it's more of a higher resistant vascular bed. Someone trying to get in. All right, I thought someone was trying to get in. So yeah, so the external carotid artery supplies blood flow to a higher resistant vascular bed, so it's going to have a higher resistive indice than the internal carotid artery. And then the last vessel that also brings blood flow up to the brain is going to be our vertebral artery. So the vertebral artery supplies the posterior circulation in the brain. We're going to see in a minute. Kind of think of the vertebral as a baby internal carotid artery. So it's going to have basically the same flow characteristics as our internal carotid artery. It's just a little bit smaller, and the velocities are lower than our internal carotid artery. Does anyone remember what the highest resistive indice a vessel can have is?
Is it 1?
1, good, very good. That's the highest resistive indice any vessel can have is 1. So we're gonna see in a minute too our formula for resistive indice. It's our peak systolic velocity, so that top peak, minus our end diastolic velocity, so divided by our peak systolic velocity. So if our peak systolic velocity is 10 and our end diastolic velocity is 0, if that line goes all the way down to the baseline, there's no diastolic flow. 10 minus 0 is 10 divided by 10. So that gives us a resistive indice of 1. So that would be, yes, that's the highest we can have is 1. And then when we talk about intracranial, we're going to focus on our circle of Willis. So some facts about the brain. The brain only accounts for about 2% of our body weight, but receives about 15 to 20% of our cardiac output and consumes 20% of our oxygen supply. But getting oxygen to our brain is critical, it's crucial. This is just our little schematic here for our vessels. So again, this is a important picture to just become familiarized with yourself. You know, hint, hint. So if you kind of just picture this line over a patient's chest.
Hey, Dan.
Yeah.
I don't know if it's just me or if your shared screen, it's just still on the first slide. Like
I see that too.
Why? I can't see where you're scrolling.
Oh, why is it not scrolling? What about now?
There we go. Thanks.
Thank you guys. I love you all. I'm sweating like crazy. All right, so there we go. I'll just kind of scroll through real quick. So again, so extracranial carotid arteries outside the cranium, common carotid, internal, external, and our vertebral. So again, so this is a little schematic, you know. So these pictures are going to be important for you to be able to label, particularly on your registry and boards. Just kind of picture this line over a patient's chest. You have your aortic arch. Your innominate artery is your first branch off the aortic arch. So if this is the right side, you have your common carotid artery coming up. This is going to be your vertebral artery branching off your subclavian on the left side. You have the common carotid, I'm sorry, subclavian, common carotid is the second branch off the aortic arch, I apologize. Common carotid coming up. And then if you get up here towards the bifurcation, that common carotid artery splits into our internal carotid artery and external carotid arteries. Vertebral artery again, branching up. So it's going to be important for us to know when I mentioned before, you know, being able to read the waveforms and telling where that stenotic lesion could potentially be. Understanding how to interpret the waveforms and realizing just having a good grasp of your anatomy and where these vessels branch off, particularly when it comes to the vertebral arteries, because we're going to learn about a condition, you know, called a subclavian steal syndrome, where patients could have stenotic lesions in the proximal subclavian arteries, and on the right side, potentially in the innominate arteries. And we'll actually be able to see flow reversal in these vertebral arteries in an attempt for the body to get blood flow out to the extremities, the arms. So the arms aren't getting enough blood flow, and the body's actually going to steal it from these vertebral arteries, and we're going to have retrograde flow. So we're going to have questions that are going to ask, you know, we have retrograde flow seen, you know, in the right vertebral, and then normal flow in the right common carotid. Where could that stenotic lesion potentially be? So if it's retrograde in the vertebral and normal in this common carotid, that stenotic lesion has to kind of be in this little area here. So after this common carotid artery, but before this vertebral artery. If I see retrograde flow or abnormal flow patterns in both the right common carotid and the right vertebral, that stenotic lesion has to be more proximal down here in the innominate, because it's affecting both of those arteries now. So those are going to be the types of questions that we're going to have to be able to decipher and interpret as we get into this, you know, this portion of the course. Don't worry, we're going to get lots of practice with these. So the brachiocephalic is the first branch off the aortic arch. It divides into that right common carotid, right subclavian. Left common carotid is the second major branch off the aortic arch, and divides into the internal and external carotid arteries. And the left subclavian is that third branch off the aortic arch. This is just kind of another breakdown diagram. There again, we can just kind of visualize your branches, again, coming off the aortic arch. So I like this one a little bit better because you can kind of appreciate how the internal carotid artery runs more posterior and up towards the brain, whereas the external carotid artery comes in more towards that patient's face, more medial and in towards the patient's face. So here we could see also common carotid artery, the bifurcation and our carotid bulb, and then our external carotid artery and internal carotid artery. As we start scanning too, we'll be able to, one of the things that might be able to give us a clue as to if we're imaging the internal versus the external, aside from, you know, our Doppler waveform, is the presence of these branches. So the external carotid artery has a proximal branch that we could potentially see. So this is going to be our superior thyroid artery. Is this first branch that we could potentially see on the external carotid artery, whereas the internal carotid artery that goes up to the brain, there are no branches seen extracranial. So the first branch of that ICA doesn't happen until you're actually up in the brain. And there's another diagram now showing now same thing, your common carotid arteries coursing upwards. And now we get into the cranium itself, up into the brain. And now we're actually into that circle of Lewis. And you can see the vertebral arteries also coursing up. Again, the vertebral arteries will join together and form the basilar artery and then connect into the circle of Willis as well. So don't worry too much about the circle of Willis right now. We're going to go into that a little bit later. This is just a little relational anatomy now. We're talking about our carotid vessels. So the CCA, the common carotids, they lie posterolateral. So behind and a little bit lateral to the thyroid gland, deep to the jugular vein and the sternocleidomastoid muscle. The common carotid artery has no arterial branches. So again, that's important to remember that there are no branches at this point. It bifurcates and divides into the external carotid artery and internal carotid arteries at the level of the upper border of the thyroid cartilage. The right common carotid artery, again, is a branch off the innominate, and the left common carotid artery is the second major branch directly off the aortic arch. So the carotid artery has a segment that we refer to as the carotid bulb or carotid sinus. This is an expanded portion of the common carotid artery just before that bifurcation, just before that split. And this is actually the most common site of plaque formation and intimal thickening. So I'm sure you guys, you can lock this up. It's going to be a registry board question. The most common location and most common site for carotid plaque or a hemodynamic stenosis to develop in is going to be in that carotid bulb. So that's where you're going to see your most of your stenotic lesions is in the bulb and in the bifurcations. Excuse me. All right, just give me 1 second. Sorry. So the reason that this happens that in this carotid bulb is we get this area of dilatation and the blood flow patterns start to change. So when we have a nice straight vessel, we get nice laminar flow. And then we enter into this area where the carotid artery starts to dilate. And then we get into the area and it's immediately before the bifurcation. So we get disturbance of that nice laminar flow pattern. Blood swirls a little bit in that area. The flow pattern becomes a little bit becomes irregular. And for whatever reason, that seems to be the location because of those change in flow patterns where we get the development of intimal plaque and thickening. And that's where we develop a majority of our stenotic lesions. So you can see here, so that little bulb area is going to be right before the bifurcation where it starts to get dilated, a little bit big. So this is a nice sagittal or longitudinal view of a nice, clean, common carotid artery. We can appreciate our different vessel layers here. So the thin echogenic layer along that blood tissue interface, that's going to be our tunica intima or intima layer. We have a small hypoechoic layer just below that. That's going to be our tunica media. And then a brighter echogenic layer just below that is our tunica adventitia. So this is again a nice sagittal view of the carotid bifurcation and bulb area. So we have our common carotid artery. So this would actually be considered our distal common carotid, then into our carotid bulb, and then our bifurcation where it actually splits. So our bulb area, and then our bifurcation where it splits. So everyone sees these nice, pretty tuning, like looks like a fork picture. When we start scanning, don't get discouraged because not everyone's going to have this nice fork. It all depends on how your carotid bifurcates, you know, if it bifurcates up and down or if it bifurcates side by side. So our extracranial carotid and vertebral arteries. Our internal carotid artery, or ICA, it's larger and more lateral. So if I kind of turn my head to the side and I visualize the vessels running up my neck, when I say it's more lateral, it's kind of being more, think more towards the posterior back of the neck. So it's more lateral, lies more lateral. It supplies most of the anterior circulation of the cerebrum, the eyes, the forehead, and the nose. It's oriented posteriorly towards the mastoid process. So towards this mastoid process, so if I'm coming up, more towards the bottom of my jaw. Again, you can identify the ICA because it has no extracranial branches. So if I'm scanning a vessel and I think it's the ICA and I see branches coming off of it, it's not the ICA. The first major branch for the ICA is going to be the ophthalmic artery. And this is actually going to be intracranial. So this is going to be actually in the brain, this ophthalmic artery branch. There's an intracranial segment as well called the carotid siphon that we're going to learn when we discuss more about this circle of Willis. The ICA, when we're talking intracranial, continues to the base of the brain, where it branches into the anterior cerebral, middle cerebral, and posterior communicating arteries. So this shows that internal carotid artery, then coursing intracranial. And then once you get intracranial inside the brain is when you get that first branch. And the first branch of the ICA is the ophthalmic artery. All right, so external carotid artery now. So the external carotid artery, it's typically smaller in diameter and runs more medial, is the more medial branch of the CCA. So it's going to run more in towards the face as I'm scanning. This supplies blood to the neck, the scalp, and the face. And the external carotid artery has multiple branches that are associated with it. So that first branch being the superior thyroid artery. So that's the one that we can typically see right near the bifurcation where it branches. So that could be our first clue, that this is the external carotid artery. Some of the other branches include the ascending pharyngeal artery, lingual artery, occipital artery, the facial artery, also called the external maxillary artery, the posterior auricular artery, the maxillary artery, which is also called the internal maxillary artery, and the superficial temporal artery. So the reason these two are highlighted is because they're probably the more common ones to be asked on your board exams. And they're important to recognize because we actually utilize these in identifying the external carotid artery. So we can use the superior thyroid artery as an identifier of the ECA just by visualizing it branching off. But we can also use the superficial temporal artery, which is located, exactly where the name implies, on the patient's temple. It's that that pulse that you feel, the bounding pulse, the artery that you feel, when you push on your temple over here, to identify the ECA by doing something what's called a temporal tap. So if you're ever scanning and you're having a hard time to differentiate, between ECA and ICA, perhaps there's some sort of stenotic plaque in the ECA that's causing the resistive indices to be lower than they typically are and appear more like the ICA, and you're not able to visualize that branch of the superior thyroid artery or any of these other branches, you can perform what's called a temporal tap, where you put oscillating pressure on that superior thyroid artery, and that pressure that you place on that artery actually gets translated back down, and you can exhibit those oscillations on your Doppler waveform in a method called a temporal tap. So that's why those two vessels are important are highlighted here in terms of being able to identify your ECA. So this chart just shows some of the branches off the branches off the ECA, and then the further branching of what those vessels then branch into. So you could also use your color flow Doppler to help you try and identify the difference between ECA and ICA. So ICA will typically have a more continuous flow pattern. So like we said, ICA is low resistance, so we should have a continuous forward flow during diastole, which will cause the vessel to remain filled with color throughout the cardiac cycle. Whereas our ECA is considered high resistant. We may have a momentary period where there is no color filling during that cardiac cycle. So where that we may get a segment of diastole where there is no forward flow. So we could potentially use that to try and determine the difference between ECA and ICA. But ultimately, the best method is to really get a Doppler waveform of the vessel. So this shows your typical waveform for a healthy internal carotid artery. So you have a nice fast upstroke and a nice slow persistent downstroke with a high diastolic flow component. You have a nice open spectral window, so this isn't filled in. You have a nice empty spectral window. So this is showing nice laminar flow. And this is a typical waveform for a healthy external carotid artery. So you can see here a couple of differences. With the external carotid artery, you'll also be able to hear the sound. ECA has more of a wispy sound to it, like almost like I want to say like a whip or a wispy sound, but like typically has a little bit of a faster upstroke as well as a faster downstroke. And with the ECA, we get a deep dicrotic notch. So that dicrotic notch will often hit the baseline or even potentially go below that baseline, depending on how healthy the patient is and the rebound of those arteries. And you have a much lower diastolic flow component to it. So if I'm measuring, peak systolic versus end diastolic, this is going to have a higher resistance indice than this guy. So this has less of a difference between peak systolic and end diastolic than this guy. So this is going to have a lower resistance. So again, like I said, we can also use the presence of the visualization of our first branch, that superior thyroid artery, and helping us to identify. So in this picture, we could see a common carotid artery branching into our internal carotid artery and external carotid artery, and we're able to visualize that first branch off our external carotid artery. For vertebral and basilar arteries, so the vertebral artery is the first branch off the subclavian artery. It supplies the posterior part of the brain, so that's the medulla and the cerebellum. Branches of the vertebral artery supply the medulla and the interior surface of the cerebellum. The vertebral artery enter the foramen of the transverse process of the 6 cervical vertebrae, and passes through the base of the skull and enters through the foramen magnum. The vertebral arteries also serve as a collateral route for the innominate and subclavian arteries in instances of arterial occlusion in these vessels. So that's what I was mentioning before about subclavian steel. So these vertebral arteries serve as a collateral route if we have stenosis or occlusion, severe stenosis or occlusion in either the innominate or subclavian arteries. So this picture shows the vertebral artery. So there's a segment of the vertebral artery in the proximal segment that doesn't pass through the transverse processes of our spine. So we have little holes in our spine and some of the transverse processes where the vertebral artery actually passes through. So we'll be able to see this on ultrasound when we're imaging our vertebral artery, depending on what level we're at. You'll actually see areas of shadowing artery, and you'll know it's vertebral artery because that's the bony processes that the artery is passing through, creating that shadowing. So that's part of the reason why, being able to determine, what your waveform is telling you in terms of the location of the disease is critical, because they might be, some plaque that we're not seeing because of the shadowing of the bone. This is a good example of what it looks like when it passes through that bony processes. So we see our vertebral artery and then the shadowing from the spine, from the spinous processes. And this shows that segment of the vertebral artery as it comes off the subclavian artery that does not pass through that bony process. So this is that proximal segment of it. Then you can see the waveform of the vertebral artery looks very similar to that of our internal carotid artery. Just think of it as the baby internal carotid artery. So the velocities are less. We don't have any grading criteria when we're talking about degree of stenosis when it comes to vertebral arteries. That's something that just applies to the internal carotid arteries. So just keep that in mind. So the basilar artery, so this is formed by the coming together or joining of the right and left vertebral arteries. This happens at the base of the pons. The right and left vertebral arteries join to form that basilar artery. It courses upwards and then divides into the posterior cerebral arteries. And then the posterior cerebral arteries supply the entire pons, the superior and anterior portion of the cerebellum, and form part of the circle of Willis. Good old circle of Willis. So this is a hexagonal arrangement of arteries composed of the following vessels. So circle of Willis is made up of our anterior cerebral arteries, the middle cerebral arteries, posterior cerebral arteries, and then the anterior and posterior communicating arteries. So we have anterior cerebral artery on the right and anterior cerebral artery on the left, a middle cerebral artery on the right, middle cerebral artery on the left, posterior cerebral artery on the right, posterior cerebral artery on the left. So I implore you guys to actually draw out a circle of Willis for yourself to help you to memorize the vessels. When you're trying to study circle of Willis, just kind of picture yourself like a bird. So it's more of a bird's eye view, looking down on the brain. So if I'm looking down from above at a person's brain, so if I chopped his head open in half, I'm looking down on top of his brain, I see, his anterior cerebral arteries coming anterior, out towards the front of the brain, or towards the anterior portion of the brain, right and the left. Middle cerebral arteries, from looking down, come out towards the lateral portions of the brain, the middle lateral portions, and then posterior coming directed more posterior towards the back of the brain for the posterior cerebral arteries. And then we have communicating arteries, because we said there's an anterior circulation and a posterior circulation. So the ICA supplies blood flow to the anterior brain, the anterior circulation, and vertebral arteries supply blood for the posterior brain. It's called the posterior circulation. But what makes the circle of Willis so amazing is that it has these communicating arteries that allow those two circulatory pathways, if there's an issue, to communicate with each other, to supply blood flow to any part of the brain to ensure, the brain's survival. So the body doesn't want to die, the brain doesn't want to die, it doesn't want to, become damaged. So these collateral channels, these communicating arteries, will open up and allow for blood flow to be shunted to areas that it's needed. So the internal communication between so these communicating arteries allow for intracranial communication between the anterior and posterior circulations, as well as between the right and left sides of the brain. So the anterior communicating artery sits between the right and left anterior cerebral arteries and allows for communication between the right and left sides of the brain. And then the posterior communicating arteries connect the posterior cerebral and the middle cerebral arteries and allow for communication between the anterior and posterior circulations. So here's our diagram for our circle of Willis. So again, so if you kind of just visualize it like your bird's eye view looking over the brain. This is going to be our anterior portion of the patient's skull or head, and posterior portion. So internal carotid artery bringing blood flow for our anterior circulation, vertebral arteries coming up supplying our posterior circulation. So ICA comes up, enters into what's called the carotid sinus. I'm sorry, carotid siphon. So this is where we see our first branch of our internal carotid artery is our ophthalmic artery. ICA does a nice little loop, and then we get a branching into the middle cerebral and our anterior cerebral. So common carotid artery, I'm sorry, internal carotid artery branches into our middle cerebral, anterior cerebral on either side. And then our communicating arteries again, our anterior communicating artery between the two anterior cerebral arteries. So that's either, remember the name, anterior communicating artery connects the anterior cerebral arteries. Again, that allows for circulation between our right and left sides of the circulation. And then our posterior communicating artery then connects into the area of that bifurcation where this ICA, middle cerebral and anterior cerebral is all split. And this allows for communication between our posterior circulation and our anterior circulation. Man. So we can have some anatomical variants that exist with our circle of Willis. Some of the most common anomalies involve absence or hypoplasia, which is underdevelopment of one or both of the communicating arteries, which decreases the collateral potential. So that's not a good thing. So if we have underdevelopment of these collateral channels, these communicating arteries, or absence of them, that makes patients more susceptible to developing ischemic brain damage if they have any sort of stenotic lesions in their carotid arteries, or if they suffer a stroke. These conditions may isolate the anterior and posterior circulations or the right and left hemispheric carotid territories. Anomalies can also occur in the extracranial circulation. These most commonly involve the origins of the carotid and vertebral arteries. So where they exactly branch off. This just shows some different configurations that could potentially exist for the circle of Willis. So there's just some also variations that could exist in patients' aortic arches. So here we have our normal aortic arch. In this case, we have only two branches coming off our aortic arch. So here we have the left common carotid actually as a branch off our brachiocephalic. So this can occur actually about 20% of the population. So we would have our left CCA, right CCA, and then right vertebral, and then left vertebral coming off our left subclavian. So we just have a brachiocephalic artery and a left subclavian artery coming off the aortic arch. Potentially they could be sharing an origin. We can also potentially have a vertebral artery coming directly off the aortic arch. So that would be for the left vertebral artery. So again, we said the brain depends, entirely on constant blood supply because there's little circulatory reservoir to the brain's high metabolic rate. There's no significant oxygen or glucose storage in the brain, so it needs that constant blood supply. Depends entirely on the vascular maintenance. Short episodes of cerebral flow interruption can bring on cerebral dysfunction symptoms or even cellular death. So, it's very important, that we always have that constant blood supply going to the brain. That's why you can, put someone in like a sleeper hold and really, knock them out. You can cause brain dysfunction just by momentary pauses in that circulation to the brain. All right, so when we start talking about now cerebral hemodynamics, there's a couple things that we have to take into consideration. So adequate perfusion, enough blood flow to the brain depends on several factors. So some extrinsic factors are systemic blood pressure. So we want to have blood pressure that's actually high enough to be able to bring blood flow to a patient's brain. I learned this when I was actually scanning, going into the stroke units, doing carotid ultrasounds, in patients who've had, TIAs or strokes or any sort of like, brain damage or brain bleeds. They actually want their patient's pressures actually a little bit high to ensure that there's adequate perfusion and blood flow getting to the brain. So if a patient's blood pressure is actually too low, that's going to impair adequate blood flow getting to that patient's brain. So systemic blood pressure is a factor that affects adequate perfusion. So if the patient's pressure is too low, they're not going to get adequate blood supply, adequate perfusion to the brain. Too high is not good as well because, that can also cause potential rupture of vessels and damage to the brain itself. But so systemic pressure, is important. Other factor is cardiac output. So how strong, is that patient's heart? If they have a weak heart that's not able to pump the blood to the brain, that's going to be a potential issue. And another extrinsic factor or external factor is going to be the patient's blood volume. So if they have low hemoglobin and hematocrit, if their blood volumes are low, that's going to not allow for proper perfusion or adequate blood supply getting to the brain. And then we also have intrinsic factors, so internal factors within the vessels themselves that control cerebral resistance. So some of those factors include intracranial pressure. So if the patient has a lot of pressure in their brain, so if they've had some sort of traumatic brain injury or, like head trauma, and you have high intracranial pressures, that's why they remove a portion of that skull to kind of relieve some of the pressure in that brain to allow for perfusion up. So just kind of think about it. If we have high pressure in that brain, blood flow doesn't want to go, blood flow goes down the pressure gradient, goes from high pressure to low pressure. So if we have increased pressure in the brain, it's going to prevent blood flow from getting to that brain. So we got to kind of try and relieve the intracranial pressure in that the brain itself. Arterial oxygen tension, carbon dioxide tension, blood viscosity, and vascular tone or some other intrinsic factors. So our CO2 and O2 concentrations actually play the greatest roles in modulating cerebrovascular resistance. So if the brain needs more oxygen, it will then produce more CO2. This increasing in CO2 causes vasodilation, which will then increase blood flow until enough oxygen had been supplied. So this is a mechanism, that the body has. It's a compensatory cerebral vasodilation system. It helps to maintain blood flow in situations where cerebral perfusion pressure drops. If disease is present, then compensatory mechanisms may be insufficient and may lead to symptoms. So what's that saying is if, a patient has carotid artery disease, they have carotid artery stenosis, some of these compensatory mechanisms that the brain has may not be sufficient enough to supply, blood flow to the brain. And that's when patients will start to develop symptoms. The brain also relies on collateralization. So capillaries and precapillaries have anastomosis. Anastomoses are common in the arteries of the brain. There are two types of arterial branches supplying the brain. We have penetrating arteries. They're important in terms of their neural and nutrient supply, and diffuse circumferential and superficial arteries. So these spread over the surface of the cerebral hemispheres, brainstem and spinal cord, through which they have collateral circulation. And then we also have the circle Willis and the major arterial trunks as supplying collateral flow. So the opening of collateral pathways is dependent on the age of the individual and the time sequence of the occlusion. Collateral flow has a better chance of developing adequately in a person with slowly evolving atherosclerotic occlusion. So if the disease process is slow to develop, that allows the body and the brain a chance to develop and form these collateral pathways. So if a person has, a sudden stroke or sudden onset of disease, say for instance, they had a clot in their heart that all of a sudden traveled out of the heart, shot up the carotid artery, went to the brain, blocked the vessel. So this is a very acute onset. The brain, isn't going to have that chance to develop, these adequate collateral pathways. And this patient, will likely develop, a severe onset of symptoms very rapidly. Also to take note is less adequate collaterals develop when multiple lesions are present as well. So if there's multiple areas of disease, these patients are less likely to have adequate collaterals. So large intra-arterial connections, interarterial connections. Again, this is going to be our circle Willis, providing communications between the two carotid arteries, so our right and left, or between the basilar artery and and the right or left carotid arteries. So connecting our posterior and anterior circulations. So we also have intracranial and extracranial anastomoses. This is called pre-Willisian anastomoses. So some of these are connections between actually our external and internal carotid arteries. So these connections exist between our ECA and our ICA through branches through the ophthalmic and orbital arteries. So between branches of the internal and external artery, between branches of the ECA and ICA. So some more of these branches are the meningeal hypophyseal branch of the ICA, connects to the ascending pharyngeal artery of the ECA. As well as the corticotympanic branch of the ICA connects to the maxillary artery of the ECA. So basically, I just want you guys to understand that there are collateral pathways that exist, when patients have disease. And these collateral pathways, we have first one, most importantly, being our circle of Willis. So this is considered a large collateral pathways, but we do have smaller collateral pathways that can open up, and we have connection between the internal and external carotid arteries. So if we have, stenosis or blockage in the internal carotid artery on one side, we could potentially get blood flow to that portion of the brain through connections that the body has between the internal and external carotid artery and some of these small branches of our ophthalmic and orbital arteries. So we have small branches that come off, the ICA and the ophthalmic arteries that connect directly to the branches off the ECA. So we can have communication between those two circulations as well. And there's also small interarterial communications. So this is a network of connecting terminal cortical branches. This is often referred to as a wonderful net of transdural anastomoses across the subdural space, from the dural arteries to arteries on the surface of the brain. So these are at a very small level and help to allow for collateralization in very small vessels. And so these are some pre-Willisian anastomoses. It's that ECA-ICA connections through the orbital and ophthalmic arteries, some branches of the orbital and ophthalmic arteries. All right, so major ECA and vertebral collateral pathways with ICA occlusion. All right, so this is an important slide for you guys to remember, because again, like I said, most of our occlusions are going to be in our carotid bulb. So that's where we're going to see most of our carotid disease. So really are focused on, patients that have an ICA occlusion. So if patient has an ICA occlusion, produces collateral circulation. So some of the collateral pathways, understanding what the collateral pathways are that I'm going to open. So some potential collateral pathways that we could see are going to be collateral circulation to that carotid siphon. So it's that bulb portion or dilated portion intracranial of the ICA. Through the ECA and ophthalmic arteries. So we have branches of the ECA that connect to the ophthalmic arteries. So we said the ophthalmic artery is the first branch. Let me see if we can get in here. So the ophthalmic artery is that first branch of the ICA. So if a patient has an occluded ICA, blood flow is not getting up to the brain. So the collateral pathway one potential collateral pathway that's going to open, the body's going to try and steal blood now from the ECA because blood flow is still getting up the ECA. And it's going to, those collateral channels are going to open up between that ECA, the branches of the ECA and the ophthalmic artery. And blood flow is actually going to now become retrograde in that ophthalmic artery and reverse and go into the ICA. So you're going to see retrograde flow or flow reversal in that ophthalmic artery to fill back in the ICA or to supply blood flow to the brain. So the other channel, some other channels that could potentially open if a patient has an occluded ICA. We have our anterior communicating artery and our the anterior communicating artery. I'm sorry, anterior cerebral artery and the middle cerebral artery are also supplied. I'm sorry. So the anterior cerebral artery and the middle cerebral artery are also supplied from the opposite anterior cerebral artery and middle cerebral artery through those communicating arteries. So if we have an ICA occlusion, we could potentially get blood flow to that portion of the brain across from right to left through the anterior communicating artery. So we could steal it. So if it's the right ICA that's occluded, we could steal it from the left side of the brain, from the left ICA. So blood flow can then be shunted from the right anterior communicating artery through from one anterior cerebral artery across the anterior communicating artery into the opposite. I'm so mess, guys. I can't believe I'm even doing this. Fever's kicking my butt.
You're doing great.
I'm spaced out. I wish I had my chalkboard with me. So I'm feeling I'm just blabbing. I feel drunk. Oh God. So just think about it. So ICA is occluded on this side. Blood flow can't get up to the brain. So we have collateral channels. So ICA is blocked, no blood flow to the brain. ECA is still open. That's supplying blood flow to the face, but it does have some branches now that connects to that ophthalmic artery that brings blood flow to the eye. So that's that first branch off the ICA. So there's some little branches that connect to that ophthalmic artery. So the brain's gonna be like, hey, I'm gonna tap into that, open those collateral channels, steal blood flow from the ECA, and now go retrograde through that ophthalmic artery into that ICA to try and bring blood flow to the anterior circulation, the anterior cerebral artery, and the middle cerebral artery on that side of the brain. The other option is going to be through the circle of Willis. So again, no blood flow going up through the ICA. So that means the anterior cerebral artery on this side and the middle cerebral artery on this side aren't going to get blood flow because the blockage isn't, blood flow is not getting up to that part of the brain. So it's going to say, hey, we'll try and get it from the other side of the brain because that side's okay. So blood flow will come up this side of the brain. If it wants to get it from this side, this ICA, blood flow is going to come up this ICA, go into the anterior cerebral artery on this side, get shunted across the anterior communicating artery into the anterior cerebral artery on the side that's affected. And you'll actually have some flow reversal or some blood flow going back down that anterior cerebral artery into the ICA. So blood flow will go in both directions. So you'll still have some blood flow going up the way it should in the anterior cerebral artery on the affected side, but some blood flow also be shunted into that middle cerebral artery and go out to feed the middle portion of that brain, the lateral portion of that brain on the affected side. So that's one way that the circular willis could work. The other way it could be too from the vertebral artery on that same affected side. So we're going to also be able to recognize there's going to be waveform differences that we're going to learn to recognize as well. So the other option too would be, all right, my vertebral artery is still good. That's bringing blood flow up to this side of the brain. Let's use that posterior communicating artery to try and bring blood flow to the areas of the brain that need it. So ICA is no good. No blood flow getting to the middle cerebral and anterior cerebral. We can tap into that vertebral artery. So vertebral artery coming up, forms the basilar artery that branches into our posterior cerebral. Blood flow that gets shunted through that posterior communicating artery on the affected side, connecting to that ICA where it's not affected, and then perfuse the middle cerebral and anterior cerebral arteries and get blood flow to that portion of the brain. So that could be an option as well when we're talking about ICA occlusion. So the body has several fail safes to try and get around and preserve itself. This is just showing some more of those collateral channels. So flow is shunted through the thyrocervical and costocervical arteries. Contralateral vertebral artery enlargement. So this just shows some collateral circulation arising from occlusion of large branch of the aortic arch. Is through intercostal and intermammillary arteries to the subclavian arteries. So if we have a large occlusion, somewhere in this aortic arch, we have additional collateral channels in our chest as well to try and get around more central arterial occlusions. So if we have a large occlusion in these branches, we have intercostal and intermammillary arteries that communicate to the subclavian and then to the thyrocervical and costocervical branches to the vertebral and carotid arteries. So there's multiple collaterals that do exist within our body, collateral channels. So again, the body is pretty amazing. It's definitely has many fail safes to try and get blood flow up to the brain. Is it scrolling for you guys? Can you see me scroll?
Yeah, we can see.
Yeah.
All right, cool. All right. So this next, any questions about any of that? So that was just a little bit basic anatomy. I want to see something. I felt like there was slides that showed like tunica intima media. Let me see something real quick. Okay, now we're good. What did I do? What did I do? So it's part of the reason why I like carotid scanning and cerebrovascular scanning so much. And one of the reasons I really got into vascular was because you really have to be a detective and understand, patients' symptoms, what they're feeling. And you felt more of like a clinician, rather than just I'm here to take pictures. Because you have to understand, how a patient's symptoms, what they're telling you, and where the disease could potentially be. So when we're talking about carotid ultrasounds, getting a very good patient history is very critical, in determining where the potential stenotic lesion could be. And guiding your exam. So basic considerations. So the importance of the carotid arteries. Many strokes are in the carotid territory. So blood that passes to ICAs nourishes 75% of the brain's tissue. So our internal carotid arteries supply about 75% of the brain. The territory that's supplied by our ICAs is about 75% of the brain's tissue. The origins of the common carotid arteries are more receptive to developing emboli or becoming blocked by emboli. So this is emboli that's from a cardiac in nature. When we're talking about atherosclerotic plaque or stenotic lesions, so plaque that develops slowly over time, these are more prevalent at our in the cerebral vasculature at the carotid bifurcations. So remember, carotid bifurcation, the bulb is going to be your most common place for plaque development. So think of the bulb and bifurcations. Ultrasound provides a fast, portable, and non-invasive way to evaluate for the potential risk of stroke. It's inexpensive, it's repeatable. So as long as you do it right, your values and numbers should be very similar to what another person does. So patient history. So again, it's important to obtain a complete history and confirm the indication for testing before performing any study. So we want to make sure we're always, doing the right thing. So indications for performing a carotid study. So these are going to be any of our stroke symptoms. So any patients that's having any sort of our stroke symptoms, we're going to learn in a little bit. So that's things like, dizziness, fainting, syncope and collapse. So if they actually drop to the ground, vertigo, any of our stroke symptoms, like, if aphasia, not being able to talk, not being able to speak, you know, paralysis or like loss of movement on one side, any sort of vision disturbances. So there's a whole multitude of signs and symptoms that could potentially indicate, cerebrovascular insufficiency. We're going to discuss the common causes of ischemic stroke. So it's important to know that there's two kinds of stroke. So we have ischemic stroke, so stroke due to poor perfusion of blood flow, so blood flow not getting to the brain, that's ischemic stroke. And then we also have something called hemorrhagic stroke. So that's stroke due to a brain bleed, so vessel rupturing and the patient actually bleeding in the brain. So those are two, very different conditions, and they're both, a term stroke. So when they say patient has a stroke, it can either be a ischemic stroke or a hemorrhagic stroke or a brain bleed. That's important to differentiate between the two. We have to be able to learn and identify risk factors and contributing diseases and the mechanisms of these diseases. So signs and symptoms. So these the extent of clinical signs and symptoms depends on the ability of collateral circulation and maintaining adequate cerebral perfusion. So what that means is, the severity and extent of a patient's signs and symptoms will ultimately depend on how well the body was able to, develop and maintain adequate collateral circulation perfusion. So if, a patient, had a sudden onset of symptoms and they were able to develop adequate collateral circulation, these symptoms might just be transient. They might just, lasted for a moment and then they're gone. If the patient had a prolonged period or wasn't able to, develop, adequate collateral pathways, these symptoms may actually, become permanent, may be deemed permanent. The patient's symptoms also depends on the territories that are affected. So we have anterior circulatory territory symptoms, as well as, posterior circulatory symptoms. And then we also have what are called non-localizing cerebrovascular symptoms. So we're going to learn some of these in a moment. So when we're talking about transient symptoms, the term we like to use is something called a TIA, a transient ischemic attack. So you'll often hear this referred to as a mini stroke. These are the patients, they exhibit, they're at home, all of a sudden, they start talking funny, not making sense. And, this is what happened, to my mother-in-law. My wife called me, she's just acting weird. She's just saying like weird things. She's not making any sense when she's talking, and she's acting weird, and then she called me back, finally said, she's fine now, it's just, she's okay. I'm like, no, you got to call the ambulance. Like she said, she had a TIA, she had a mini stroke, this is a transient ischemic attack. So by definition, a TIA is a focal neurological deficit. So this is a neurological symptom or neurological deficit where the patient has full recovery in less than 24 hours. So the symptoms last for less than 24 hours and they have a full recovery back to normal function. So whatever that symptom was, if it was, droop face or like, drop attack, or, they weren't able to use an arm, process of an arm, they have full return of, mobility to that arm. Or if it was a vision disturbance, they have vision disturbance in an eye, they have full regain of their vision, within 24 hours. So that's the clinical definition of a transient ischemic attack. They have full recovery of their neurologic deficit within in less than 24 hours. So those neurological deficits, they could be sensory, they could be motor dysfunction, against, like I said, speech impairment, headache, dizziness, tingling, numbness, blurred vision, confusion. So, sudden altered mental status, so just, this could be particularly difficult, in elderly patients that do have dementia, how do you can really tell, if this patient, is suffering from some sort of, ischemic attack, or if it's just, dementia, can be a little more challenging. And again, their symptoms are going to vary depending on the territory that's involved. So these are usually due to some sort of embolic event. And these could be a warning sign, of an impending signs, an impending stroke, or even a heart attack. In patients with, a transient ischemic attack, there's a medicine called TPA. So this is a clot busting medication. It's a very powerful medication that can be administered. And if it's administered within and it has to be administered within 3 hours of onset, after the onset of symptoms, to break down, that embolic or that clot, that's blocking the artery that's causing these symptoms. So that's why it's important, time. They always say time is such a factor when dealing with stroke. The faster they can get the patients in and evaluated and assessed, and administer, this TPA, the better the outcomes are going to be, because you only have a narrow window, that 3-hour window, to be able to administer this medication. So moving up the chain in severity from transient ischemic attack, the next thing we have is something called RIND. So this is reversible ischemic neurologic deficit. So these are patients, by clinical definition, that have a neurologic deficit with full recovery within 3 weeks. So these are patients, they exhibit some sort of stroke symptom, and it lasts for more than 24 hours. By clinical definition, they have full recovery within 3 weeks. So this is good. And then we have let's call the next, moving up in severity, the next thing is what's called a CVA, or cerebrovascular accident. So this is a CVA is what is considered a true stroke. So up here you see mini stroke. This should actually just kind of be in, in air quotes, mini stroke. It's not really a mini stroke, A true stroke is a cerebrovascular accident. So a transient ischemic attack, TIA, full recovery from symptoms within 24 hours. RIND, a reversible ischemic neurologic deficit. We get recovery within 3 weeks. And then a cerebrovascular accident, or CVA. This is a true stroke. This is an ischemic attack that lasts longer than 24 hours and shows evidence of profound cerebral damage. These patients have permanent neurologic deficits, so they don't regain, those functions. They have some degree of permanent neurologic deficit. These patients will go, to physical therapy. They'll try and regain, some of the function that they've lost. But there is some degree of permanent neurological deficit with these patients. Again, like I said, when we're talking about cerebrovascular accident, or CVAs, there are two types of strokes. We have our ischemic stroke, and then our hemorrhagic stroke, our brain bleeds. So I'm going to talk now just specifically about ischemic stroke. So due to ischemia, not enough perfusion of blood flow getting to the brain. So think anytime ischemia, stenotic lesions, so narrowing of the vessels. So this is brain infarct due to insufficient blood supply. So it's caused by atherosclerotic plaque. Could be caused by thrombosis, so clot or embolism. So it can be thrombotic in nature or embolic in nature. There's also something called a lacunar stroke. So these are very tiny ischemic strokes. These cause occlusive lesions on small perforating vessels. We can also have something called a cryptogenic stroke. So this is a stroke of an unknown cause. So ischemic stroke is due to insufficient blood supply, whereas a hemorrhagic stroke is due to a rupture of an artery or vein that allows blood to flow into and around the brain, actually causing compression of the brain. So some causes of hemorrhagic stroke. So this can be caused by hypertension. So patient has, severe uncontrolled hypertension. Over time, we said hypertension damages the vessel, damages the walls of the vessels, and can cause a propensity for those vessels to actually rupture and bleed. Can be due to rupture of an aneurysm. So a patient may have an aneurysm in the brain. It can also be due to vessel rupture can actually occur due to atherosclerotic plaque. So the atherosclerotic plaque also damages the vessel wall, weakens the integrity of the vessel wall, and can potentially lead to rupture of that vessel. So parenchymal or cerebral hemorrhage stroke. This is usually a result of high blood pressure and atherosclerosis working together. It's a bad combination. We can also have what's called a subarachnoid hemorrhage stroke. So you may see some of these indications. So this is what's usually a result of an aneurysm rupture. And we can also potentially have something called a hypotension stroke. So remember I said we have to have adequate blood pressure or high enough blood pressure to supply the oxygen, supply the blood flow with sufficient blood supply. So that's patients that have low blood pressure. The low blood pressure reduces oxygen supply to the brain. So it could be due to hypotension. Hopefully I don't get to this point by the end of the week. Oh God. Symptoms by sight. So we're going to learn now that patient symptoms are very specific depending on which vessel is affected. And we'll tell you the territory that's involved in the brain. So the first one we're going to discuss is our anterior circulatory symptoms. So anterior circulatory system, that's going to be ICAs. So anytime you hear anterior circulatory symptoms, it's going to be our ICAs. That's going to be our primary source. Again, our most likely source of blockage is going to be in our carotid bulbs and bifurcations. So if it's the ICAs that's going to be affected. We also have to be concerned about blood flow not getting to our anterior cerebral arteries and middle cerebral arteries. So some of the symptoms that are associated with patients that have anterior circulatory issues. First one's going to be hemiparesis. So this is a slight paralysis or weakness affecting one side of the body. So hemiparesis. So don't get confused with complete paralysis and hemiplegia. So this is just a slight paralysis. So think of this as like right-sided weakness. So this patient, when they do their neurological test, they could push really strong with one arm, but the other arm they're pushing really weak, or they're kind of like, they can't really lift the one arm up very well. So this is a slight paralysis or weakness affecting only one side of the body. So hemi, meaning one or unilateral, one side of the body. Another symptom is hemiplegia. So this is actually complete paralysis now of one side of the body. So they can't move that arm at all. They can't move that leg at all on that side of the body. So these are going to be unilateral, one-sided symptoms. Hemiparalysis, hemiparesis, hemiplegia. There's another symptom called paresthesia. So this is hemiparesthesia. So only on one side of the body, a unilateral symptom. So paresthesia, this is referred to as abnormal sensations, like patients have described it to me as like a burning or prickling sensation. They almost feel like there's like ants or something crawling on their skin that it's a very unusual prickling sensation. They feel like something's crawling on their skin, and it could be very painful at times. So it's an abnormal tingling or burning sensation that they have affecting, again, only one side of the body. So I'm just going to focus on these three for 1 second. So these three symptoms, I kind of use my neck as my line of demarcation when we're talking about stroke symptoms. So these patients have symptoms on one side of their body, pick right or left, doesn't matter. I use my neck as my line of demarcation. So if a patient is having symptoms on their right side of their body, if it's below the level of the neck, it's going to be the contralateral ICA that's affected. So symptoms that are below the level of the patient's neck. So if they're in the body, so if he's having right-sided weakness, right-sided hemiplegia, right-sided hemiparesthesia, it's going to be the left ICA that's affected. So it's the contralateral ICA that affects the right side of the body. So conversely, if it's the patient's symptoms on the left side of the body, it's the contralateral, it's the opposite ICA that's affected, or it's the vessels on that side of the brain that are affected. Just take a moment to kind of just think about that and digest. So again, I use my ICA or my neck as my line of demarcation. So if patient's having symptoms on this side of the body, it's this side of the circulation that's affected. So left side of the body, right ICA, right side of the body, left ICA, or left side of the circulation that's affected. Left anterior circulation is affected. Just take a moment to kind of digest that. So anterior circulation symptoms, they're going to be unilateral, one side of the body. And if the symptom is below the neck, if it's the right side of the body that has the symptom, it's the left side, left ICA or left anterior circulation that's affected. If it's the right side of the body that's affected, it's the left. Oh, did I just say that? It's the left ICA. So just think it's opposite. Once you get below the neck, the symptoms don't correlate with the side. It's the opposite. So below the level of the neck, it's the opposite side of the body and the opposite side circulation. So they kind of flip flop. There's like I think of like an X right there, at that level of the neck. So, because we're going to see in a moment that we can have unilateral symptoms, in the eyes with vision disturbances. And when we have vision disturbances in the eye that are unilateral, it's the same side that's affected. So again, these are called lateralizing symptoms. They refer to either right or left. So anterior circulatory symptoms are considered lateralizing because we can they're isolated to either the right or the left side, and we can ascertain or determine which vessel is affected based on the symptoms. So some more anterior circulatory symptoms. So we have aphasia or dysphagia. So there is a difference between the two. So aphasia, that's a complete loss of the function of speech. So these are the patients, when you come in and you ask them, hey, what's your name? Can you tell me your name and date of birth? They just look at you blank. They can't even speak. They're just. Whereas the patient who has dysphagia, they may sound like they're drunk. They may have slurred speech. They might be saying kind of random words that don't make any sense to you. And they might have like gargled speech, or they're like, so that would be someone with dysphagia. This one always tongue ties me. Holynymus heminopsia. God, I can never say this right. So this is a blindness or a vision defect that affects the vision and half of the person's vision field on the opposite side of the lesion. So it's so the way it's weird. So it's a blindness or vision defect in half of the visual field on the side that's opposite of the lesion. So in their vision, so half of their vision field is gone on the opposite side of the lesion. So this one's a little bit trickier to memorize. So in this case, if this is the patient's, if the vision defect is on the left side, so these are the patient's two eyes. They've lost half their vision in one eye on the left side. And on this side, this eye, it's also on the left side of their vision field. The lesion is going to be in the right ICA. So this is a blindness that affects both eyes, but it has to do with their field of vision. A more common symptom is going to be amaurosis fugax. I apologize. So this is a transient, again, a temporary monoocular blindness. So amaurosis fugax is a transient blindness. So it's temporary or complete partial or total blindness, usually of only one eye. And this is due to occlusion of the ophthalmic artery. So this symptom is going to be on the same side of the disease. So on the ipsilateral or same side of the disease. So this is a very common registry question to know that amaurosis fugax is this temporary vision loss. They kind of call it as someone pulling a shade down over your eye. So it's a partial or temporary blindness in one eye that's temporary. And it's due to the occlusion of the ophthalmic artery on that same side. So the ipsilateral disease side. So if a patient also has symptoms, say they have facial droop on one side, or their pain and numbness or their tingling again is on the right side of the face, it's going to be the right, anterior circulation that's affected. So if they have that hemiparesthesia, that tingling or burning on that side of the face, it's going to be, associated with that that side ICA. So again, kind of use your when we're talking with amaurosis fugax, it's the same side. All right, so then we have our posterior circulation. So any questions about anterior circulation? So anterior circulation, it's going to be ICA, ACA, anterior cerebral, middle cerebral arteries, which supply blood flow to those hemispheres. These are going to be unilateral symptoms. When we're talking about hemiparesis and hemiplegia. So when we're talking about weakness and paralysis and that abnormal tingling and burning sensation. Again, aphasia and dysphagia, loss of speech and slurred speech, also associated with anterior circulation. All right, so then talking now about posterior circulation. So now this is going to be our vertebral arteries or basilar or our posterior cerebral arteries. So this, if you think about it, what portions of the brain and supplies, it'll help you to understand, some of these symptoms that are associated with it. So the main portion of the brain that, the posterior circulation supplies is our cerebellum. And if you remember back to A&P, cerebellum, that portion of the brain, it controls our balance and coordination. So these symptoms have a lot to do with balance and coordination issues. So one of the first symptoms now is patients that now have bilateral vision disturbances or blurring. So again, this is now bilateral symptoms, bilateral vision disturbance or blurring is associated to our posterior circulation. So these are considered non-lateralizing, so not affecting right or left. Patients who have diplopia, double vision. Patients who suffer from drop attacks. So this is a falling to the ground with no other symptoms and no loss of consciousness. So these are patients that just out of the blue just drop to the ground. They haven't fainted, they haven't lost consciousness, they just drop like a ton of bricks. Dysphagia. So this is difficulty swallowing. So don't get dysphagia confused with dysphagia with an S. So S, speech. Phagia with the S is with speech. Dysphagia with the G has to do with swallowing. So that's me right now. I have dysphagia. Some additional posterior circulatory symptoms. These are patients that have ataxia. So ataxia, this is muscular incoordination. So this is the patients that if you hold out a pen, and you tell them, all right, grab the pen, they can't, grab the pen properly. They're like reaching, improperly. They can't reach out and actually grab that pen, or they can't, touch their finger to their nose. They're going like this, they're touching their forehead, their chin. This could also be patients, that, they try and walk, they're walking with like an abnormal gait, they're walking kind of funny now. Again, now we're talking about bilateral symptoms. So again, anterior circulation, these are all unilateral symptoms. So if a patient now has bilateral symptoms, we're now concerned with posterior circulation. So now bilateral paresis. Or bilateral paresthesia. Excuse me. Vertigo. So that's the big one. Again, we were talking about that cerebellum controlling coordination and balance. So these are patients now that have vertigo. So vertigo is that sensation of feeling like things are spinning around you, These patients, they have difficulty maintaining their balance and equilibrium. So it's different from dizziness and lightheadedness. They actually feel like things are actually spinning around them. And then we can have stroke symptoms that are non-localizing. So with these, we can't really tell, if they're associated with anterior or posterior circulation. So some of these symptoms are things like headache, confusion and memory loss, syncope. So this is fainting or blacking out with a temporary loss of consciousness. Dizziness. Dysarthria. So this is affecting muscles of the mouth and the tight tongue. Patients that hear auditory disturbances. So patients that hear noises. This is just a chart just showing, again, some poor the circulatory territories and some potential symptoms. So again, the acronym we like to use for stroke is FAST. So face drooping, does one side of the face droop or is it numb? Ask the person to smile. Again, does the smile look uneven? Arm weakness, is one arm weak or numb? Are they able to raise both arms or does one arm drift downward? Speech, is the speech slurred? Are they unable to speak? Is it hard to speak? Ask the person to repeat a simple sentence like the sky is blue. And can they repeat that correctly? And the last part of that is time. So it's time to call 911. Because again, we said we have that 3-hour window to administer that TPA, that clot busting agent, to reperfuse the brain. It's important to, check what time that the symptoms appeared. Time is critical. So, if you're going to call 911, be cognizant of, the time of the onset of the symptoms. And just some more causes for ischemic stroke. So atherosclerosis, being the big one. So that's that development of the stenotic lesions that build up a plaque. And where's that plaque going to build up? In our carotid bulbs and bifurcation. So the carotid bulb is going to be your most likely location for an atherosclerotic stenotic lesion. Another potential source could be, again, embolism from the heart. So patient has some sort of clot in their heart, breaks off, travels, embolizes, goes up the carotid arteries, gets lodged. Patient can have hypertensive arteriolar sclerosis. Another potential cause of an ischemic stroke could be a dissection. So if we actually now have, separation of that intimal and medial layers, this can result in reduced perfusion or blood flow getting to the brain and could potentially lead to an ischemic event. If a patient has a pre-thrombotic state. And another one being what's called a vasospasm. So vasospasm is, as the name implies, is a muscle spasm on the actual blood vessel itself. So the artery itself spasms, constricts, causes a stenotic lesion or ischemic lesion, and doesn't allow for adequate perfusion of blood flow to the brain. So this actually happens within the brain itself. So we have vasospasm of the vessels within the brain. When we get into our intracranial vasculature and talk more about circular visualis, vasospasm is very important because this is often a byproduct of patients who've had traumatic brain injuries. They're more susceptible for developing vasospasms and are often monitored for the development of vasospasm. So they're on, some patients might be on continuous, 24-hour or even longer than that, continuous monitoring through continuous monitoring with continuous transcranial Doppler monitoring for vasospasm. Atherosclerosis. So up to 15% of cerebral infarcts are associated with embolic debris and thrombi originating from atherosclerotic plaques at the carotid bifurcations. So what's that saying? That plaque can actually break off from our carotid bifurcations and from our bulbs and then travel as embolic debris and get lodged into the smaller vessels in the brain, causing an infarct or ischemic event. The most common form of atherosclerosis. So the most common form is atherosclerosis. Again, atherosclerosis is the thickening, hardening, and loss of elasticity of the arterial wall. Arterioles. Most common form of arterial atherosclerosis is the most common form of arterial sclerosis. So arterial sclerosis is that hardening and thickening and loss of elasticity of the arterial wall. So remember back, arterial sclerosis is the hardening of the vessel wall. Atherosclerosis is the buildup of that lipid plaque. Again, the most commonly located at the carotid bifurcation origins. The carotid bifurcations. It's also most commonly located at the origins of the vessels. So we could potentially see this at the origins of the CCA, origins of the vertebral arteries. It can also potentially be seen at the distal vertebral arteries, because we have the coming together of those two arteries there. It can be seen at the proximal and distal basilar arteries, because again, we have separation of the vessels, seen along the aortic arch. And then with atherosclerosis, we have to worry about stenosis, thrombosis, embolism, and occlusion of the vessels. So this is the mechanisms of cerebral vascular disease and embolic infarct. So patients start developing atherosclerotic plaque, builds up and starts developing a stenotic lesion. It's not until we get over a 50% reduction in the diameter of the vessel that this stenotic lesion becomes what's called hemodynamically significant. This can continue to get worse and worse and eventually lead to actual occlusion of the vessel itself. Other potential issues with atherosclerotic plaque involve embolic infarct. So little pieces of that plaque actually breaking off and then traveling and getting lodged into the smaller vessels higher up. So potentially getting lodged, in the vessel, in the ophthalmic artery, getting lodged, potentially in the smaller vessels and in branches of the anterior cerebral or middle cerebral arteries. Atherosclerotic changes at the carotid bulb. So in A, we see a stenotic lesion. So we could see that this is the external carotid artery. We can see our branches. So we know this is the internal carotid artery. See the development of atherosclerotic plaque. So we're going to learn a little bit later how to, describe and characterize the plaque, because we have different kinds of plaque that develop. And as the plaque, becomes more heterogeneous and ulcerated through the development of these surface platelets, as the plaque becomes more ulcerated, it develops a higher propensity for developing embolism and breaking off. So the plaque kind of goes through a process where you can wind up with these surface platelets developing that starts to break down the plaque, and you wind up with an embolic process. And if that stenotic lesion becomes severe enough where it actually occludes the entire vessel, we can then wind up with thrombosis in that vessel if it becomes completely occluded. So the most common source of embolism when we're talking about our carotid arteries is going to be embolism from the heart. So important to remember that the embolism from the heart may not be actual clot itself. It could actually be, could potentially be from a valve vegetation. So valve vegetation, this is a process called endocarditis. So these are little bacterial infections that grow and colonize and form these bacterial colonies on the valves of the heart. And these vegetations can break off and become mobile. And when they leave the heart, they could potentially wind up in the carotid arteries and be a source of emboli. Another source of emboli could be intracardiac thrombi. So they can actually be a blood clot within one of the chambers of the heart. So it has to be on the left side of the heart when we're talking about intracardiac thrombi. Same thing with valve vegetations. All these valve vegetations have to be from the left side of the heart, because if it's on the right side of the heart, the final destination is going to be the patient's lungs. So that's not going to, find its way over to the left side of the heart and eventually into the carotid arteries. So all these things are going to be conditions on the left side of the patient's heart, or left-sided heart structures. Myxoma is an intracardiac tumor that's typically found in the left atria. So pieces of this cardiac tumor could potentially break off and embolize, be a source of emboli. Patients could have irregular heart rhythms like atrial fibrillation or AFib. This could lead to the potential development of thrombi within the left atria and could be a source of embolism. Patients who have mitral stenosis, my CVS ladies are probably all shaking their head. Mitral stenosis. So this could potentially also lead to the development of thrombus within the left atria. Potential patients who have prosthetic valves are more susceptible to developing endocarditis or these vegetations, as well as they're more prone to developing thrombi. Patients who've had a heart attack could potentially put the heart in a condition for developing intracardiac thrombi. Then bacterial endocarditis, that ties in with that valve vegetations. So just know that there's a whole multitude of cardiac sources of emboli, not just actual clot itself. So hypertension, elevated blood pressure can contribute to heart disease. So again, hypertension, it worsens or accelerates atherosclerosis, so development of that plaque. So that high blood pressure damages the wall. That damage to the wall, the body's going to try and heal it and repair it. So that damage and healing leads to thickening and scarring and more damage, and just leads to worsening of that atherosclerotic plaque. So that repeated process of damage and repair leads to thickening and scarring of that vessel wall, and eventually, reduces the diameter of the vessel wall. Hypertension can also injure small vessels of the kidney and the brain, causing a change known as arteriolar sclerosis. And this can lead to occlusion of the arterioles. So this is our carotid dissection. So again, if you remember back to last semester when we were talking about dissections, so this is a separation of the intimal layers, the intimal and medial layers, and we now have a true lumen and a false lumen that develop. So this dissection can lead to stenosis or even possibly occlusion. It can also lead to the presence of thrombus formation, as well as pseudoaneurysm or false aneurysm formation. Patients can also be in pre-thrombotic states. So abnormalities in blood coagulation that causes a tendency to thrombose. So this is a significant cause of stroke in young people. So this is patients that have some sort of underlying coagulation abnormality. Then vasospasm. So this is narrowing of the lumen of one or more intracranial arteries due to contraction of the arterial smooth muscle or to a morphologic change of the blood vessel wall. So think of it as a spasm. So that vessel is all of a sudden spasming, so it constricts. A muscle the muscle gets really tight. The smooth muscle that surrounds that artery gets tight, causes a stricture. Large blood vessels near the base of the brain are primarily affected by vasospasm and reduced blood flow, and this may result in hypoxic ischemic brain injury. So like I said, these vasospasms are intracranial arteries often occur after a subarachnoid hemorrhage and is a significant cause of stroke. So these are the patients that have had some sort of brain injury or brain bleed or some sort of traumatic brain injury. They run a high risk of developing vasospasm and need to be monitored. So risk factors and contributing diseases for carotid disease. So again, so now it's going to be all our arterial risk factors. So hypertension, it's going to be our big one. Hypertension is very prevalent in our society today, and that is a major causative factor in the development of atherosclerotic plaque. So that hypertension damages the vessel walls. The vessels try and heal themselves. The hypertension damages again, the vessel heals. So that process of damage and healing leads to the development of this atherosclerotic plaque. Diabetes, again, that's our other big one. Smoking, excuse me. So nicotine irritates the intimal lining and causes vasoconstriction. High cholesterol. So having high levels of cholesterol is associated with development, again, of atherosclerotic plaque. I don't know if anyone's ever gotten a chance to go up with IO to do a CM endarterectomy when they actually open up the guy's carotid artery and take out the plaque. It's pretty gross what it looks like. So again, so major risk factors: hypertension, diabetes, smoking, high cholesterol. So those are going to be your biggies. Some other risk factors contributing for carotid artery disease: patients that have any sort of heart diseases, so AFib, mitral valve prolapse. Other risk factors include gender and race. Some men are more likely to develop, have a higher propensity of developing strokes. Obesity plays a factor into that too. Age, so you're more likely to get a stroke the older you are. There's a familial history component to it. So typically patients, will have a familial history of having stroke or heart disease. There's a hereditary component to it. Any sort of previous medical history that might make you susceptible to developing stroke. Vitamin B deficiencies that make you more susceptible to developing thrombi that could lead to potential stroke. All right, so mechanisms of disease. So the two most common causes of brain ischemia, so hypoperfusion, low perfusion, or also called cerebral insufficiency, so poor or insufficient blood flow getting to the brain. So the two main causes of that are going to be hypoperfusion, so poor perfusion, or low perfusion. That's going to be a result of either stenosis or, a blockage in that artery, occlusion of that artery being completely blocked, embolization or thrombosis in that vessel. So it can be due to hypoperfusion, poor perfusion as a result of those things, or it can be due to brain ischemia or poor perfusion to the brain could be due to embolization. So those are the two most common causes. So something traveling up the carotid arteries and embolizing and getting lodged in the arteries in the vasculature in the brain. Again, other causes can be aneurysm, potential dissection, non-atherosclerotic lesion, something called a carotid body tumor. So we'll learn about that in a moment. And then subclavian steal syndrome. So these could be some other causes for cerebrovascular insufficiency or poor brain ischemia. So hypoperfusion stenosis. So this is going to be atherosclerosis is a common pathological condition. Again, with the arteries thicken, harden. So that's going to be our buildup of plaque. Again, where? In our carotid bulbs and bifurcations. So hypoperfusion or poor perfusion can also be due to occlusion. So arterial occlusion is diagnosed with absence of arterial pulsation. So if we don't feel an actual, if the doctor or clinician doesn't feel an arterial pulse, we can see on ultrasound with echogenic material filling the arterial lumen. In order to diagnose a true arterial occlusion versus a stenosis or trickle flow, we have to demonstrate absence of flow, both color flow and spectral Doppler. I would implore using both, not or. I would say and also I always put when I want to diagnose that this artery is truly occluded, put your power Doppler on. To try and detect, the slow flow. Occlusions, particularly if it's chronic in nature, the vessel will start to diminish in size. So you'll have a small vessel size in patients that have chronic occlusion. So in the patients that I've scanned that, I've had ICA occlusion, I can see the common carotid coming up. I can see maybe ECA still open, blood flow getting into the ECA, and then that echogenic intraluminal echoes, in that proximal portion of that ICA, and then it just kind of tapers and gets really small, and you really don't see much past mid ICA at that point. That's patients that have had a chronic, long-standing occlusion. So this diagram is just showing the right internal artery stenosis. and a left internal artery occlusion. Uh, right. So now we have some Doppler images and ultrasound images for a patient who has a bilateral carotid stenosis. Let me see if they give the chart now. So I'm not going to throw numbers at you guys yet, but so- but when we're doing carotid ultrasounds, it's important for us to get quality 2D and color imaging to show, areas of the vessels that are patent, being able to identify, where the stenotic lesion is and being able to Doppler through that stenotic lesion. So you're going to sample multiple times working your way through stenotic lesions. I'm going to teach you guys the techniques, how to do this properly, how to, when you find a stenotic lesion, how you increase your scale, your PRF, to try and reduce the aliasing to really maximize where those fastest velocities are and ensuring that your angles are correct as you Doppler through. So this is something called trickle flow in the ICA. So this is a patient that has, a significant amount of intraluminal plaque within their ICA. And just on initial analysis, it looks like, hey, this ICA is occluded. You have the CCA coming in and then the patient's ICA. So initial assessment, looks like this ICA is occluded. The top ICA appeared to be occluded. The bottom showed trickle flow in the ICA. So when in fact there was actually still some flow present within the ICA. So it's important, to maybe take a different angle, a different approach, optimize all your settings, utilize your spectral Doppler as well. So he was able to also get a spectral tracing. So this is, again, now this is our post-stenotic TARDIS parvis waveform. So it's another good example of that. See a slow TARDIS late upslope, and it's reduced a very diminished velocity. That's a good example of your post-stenotic TARDIS parvis waveform. Again, the sonographer utilized their power Doppler setting to demonstrate some trickle flow in this patient's ICA. So it's important, to be able to demonstrate that there still is some flow, because this will determine, what the, physician or vascular surgeon is potentially going to do about this stenotic lesion. So once the carotid artery, internal carotid artery, becomes completely occluded, there's nothing that they can do. There's no corrective procedure that they do, to go in and remove that that plaque or that clot. If there's still some trickle flow getting through, if there's still some patency to that carotid artery, then they're able to potentially, do an endarterectomy to try and remove this and, save that vessel. So that's why it's critical for us to be able to ascertain if there's still flow getting through that vessel. So this is a patient that has a CCA occlusion. So here we can see the patient's common carotid artery completely filled with intraluminal echoes. They put color on, didn't demonstrate any flow. But there's something unique that goes on in patients that have a common carotid artery occlusion. We actually get flow reversal in our external carotid artery. So blood flow is reversing the ECA to try and supply blood flow into the ICA to meet the demands of the brain. So this is something that we could potentially see in patients that have a CCA occlusion. So this would be more likely be someone who had some sort of, embolic event, a clot came from the heart, or some sort of thrombus came from the heart, got lodged in the ICA. And now in order to get blood flow into that, clot got lodged in the CCA. And now in order to get blood flow into that ICA, the body's actually going to steal it from the ECA. It's going to go down the ECA retrograde and then into the ICA to go up to the brain. Because again, the brain is the most vital organ. And the body's going to do whatever it can to try and get blood flow there. So this next one shows an ICA occlusion. So the ICA again is minimally filled with echogenic material. And we can also see that the ECA also has stenotic lesion as well. So this patient's CCA, ECA, and then ICA. We also have to get used to looking at these sonographic images and just remember that, this is going to be the patient's head. This is the patient's heart or feet or inferior. So this is superior, this is inferior. So this is going up. So just remembering your flow direction and blood flow when we're looking at these images now. Because we got used to imaging the legs and where blood flow is going the other direction, blood flow is going down this way. Or even in the arms, blood flow going out towards the arm. But just remember your flow direction. So hypoperfusion, we mentioned thrombosis. So the formation or presence of this is the formation or presence of a thrombus, clotting within a vessel, which may cause the infarct of tissues that are supplied by that particular vessel. So thrombosis can be secondary to stenosis or an embolism. So we can have thrombosis of that vessel or clotting of that vessel that can be secondary to a stenosis or an embolism. So just remember the definition of an embolism, embolization. It's a foreign substance or a piece of thrombus that moves through the circulatory system until it lodges in a distant blood vessel, causing an embolism by completely or partially obstructing the vessel. And then remember that the heart is the most frequent source of emboli. Another source of emboli could be, again, from that atherosclerotic plaque breaking off and then embolizing. It's just recapping on our Definition of aneurysm. So aneurysm is going to be that dilatation, a localized dilatation of the blood vessel that can be due to either a congenital defect. So that could be a patient that has some sort of, connective tissue disorder like Marfan syndrome or Ehlers-Danlos syndrome, or it could just be due to a weakening of the vessel wall. So, as a patient ages, they have weakening of that vessel wall, they're more prone to developing an aneurysm. Again, we said things like smoking can also damage the integrity of the vessel wall, lead to vessel wall weakening. Also things like, diabetes and hypertension can also weaken and damage that vessel wall and make patients more susceptible to aneurysm. Infection, so it can also be mycotic aneurysm. So infection and infectious process can also weaken and damage that vessel wall. So important to note that aneurysms within the carotid arteries, they rarely occur within the cervical carotid artery. So it's very rare for us to actually encounter an aneurysm in the segment of the carotid arteries that we're actually imaging in the neck. If we do, it's going to be more likely a result of a trauma or some sort of traumatic event that damaged that vessel. So this shows a CCA aneurysm. It's just proximal to bifurcation. And then what they did in this case, they actually placed a stent in immediately distal to the aneurysm to try and correct it. Carotid dissection. So again, we said this was a separation of that intimal and medial layers. Could also potentially have a tear between the media and adventitia layers, but more common between that intimal and medial. Results in the development of a true and false lumen. Some etiologies or causes could be, again, patients that have some sort of congenital defect, patients who suffer from FMD or fibromuscular dysplasia. So I don't know if you guys remember back that this FMD, this is a condition that affects women. It affects some of the other vessels that it can affect, in addition to the carotids, are going to be the renal arteries. So it associates FMD to women. Trauma is a big risk factor for development of dissection. Neck manipulation, so rapid neck manipulation. So if you twist your neck suddenly or too fast, you could potentially give yourself a dissection. Underlying weakness of the muscular layer that allows the intimal to tear. Even potentially excess coughing or sneezing with respiratory infection. Or it could just be idiopathic, on some unknown cause. So some things with the false lumen. The false lumen is going to have a blind end. And due to that blind end, blood flow is going to enter into that false lumen and it's going to try and exit out. So when you might see, two different colors, it may appear as there's bidirectional flow within the vessel. So that would be a telltale sign that you know this patient has a dissection. If you put your color on and you see one channel of red and one channel of blue, patients will also tend to develop thrombosis within that false lumen. So thrombus or clot formation will develop. And because the false lumen is typically larger, this causes a stenosis or occlusion within the vessel. Carotid dissection. With carotid dissections, it's usually asymptomatic. They may present with hemispheric ischemic symptoms. They may also present with cranial nerve palsy, headache, facial or neck pain. The consequences of a dissection are going to be stenosis or occlusion. They can also potentially develop a pseudoaneurysm. They're usually treated with antithrombotic and antihypertensive medications. So they want to try and lower the pressure, because elevated pressures are just going to put more stress on that vessel and further create the dissection, extend the dissection. When we talk about the origins of dissection, where they typically originate from, so they usually originate in the aortic arch and may extend cephalad or upwards into the CCA and into the bifurcations and branches in ICA. Cervical carotid arteries may undergo dissections spontaneously, and they may originate in the ICA or be involved in the CCA. So when we talk about cervical carotid artery dissections, they're typically a result of hypertension or fibromuscular dysplasia, non-violent trauma like strenuous exercises or rapid neck motion, or patients that again have underlying medical conditions, those connective tissues disorders, like I said, Marfan's, Ehlers-Danlos, or cystic medial necrosis. Dissections may also be caused again by trauma, so direct injury to the ICA. So just remember, you know, your appearance of a dissection. In our transverse view, you're going to see that echogenic intimal flap extending across the vessel. So it'll look like a thin membrane that moves freely within the arterial lumen. These are just some more transverse views for a dissection. And if we turn in sagittal, we should be able to see that intimal flap elongate. So this is again showing a CCA dissection with two channels of flow. So one being the true lumen and one being the false lumen. So the true lumen is going to have the continuous forward flow because that's continuing on to the brain, whereas the false lumen will have an irregular flow pattern. So systole blood going into the false lumen, perhaps it's hitting that blind end. You get a reversal of flow going back out, and then a return back to baseline. So this is like an obvious abnormal waveform for something that we'd expect to see within the carotid arteries. So you can Doppler to, get a better assertion as to which is the true and the false. So the false lumen is going to have this to and fro or bidirectional flow. Um, so again, CCA dissections. So color, you can potentially, see two channels of flow with different colors. So whenever you're taking your boards or you're studying for an exam, you can't ever have flow that's normal going in two different directions in the vessel. Like this. So this is a telltale sign that this patient has a dissection. And if you Doppler your true lumen and your false lumen, the true lumen will have the continuous forward flow, whereas the false lumen will have, your to and fro or biphasic or triphasic flow. So this bidirectional flow. So if this dissection has been long-standing and they're starting to develop thrombus within that false lumen, that developing thrombus is going to compress the true lumen and create high velocity stenotic lesions. So it's just an example of the true lumen. It tapers distally because it's being compressed by the thrombus. So this is that false lumen that's developed thrombus. And it's now compressing the true lumen, creating turbulent flow and elevated velocities. This is an extension again. So again, the origin of most of these dissections are going to be from the aortic arch and then extend upwards into the carotid arteries. So this is just our classification when we're talking about dissections. So we can use something called a Stanford's classification. So this divides dissections into type A or type B. So type A is called an ascending arch dissection. And it's usually associated by atherosclerotic disease or elastic tissue degradation. So those are patients that have Marfan's or Ehlers-Danlos syndrome. Type B dissection is located distal to the aortic arch. And this usually does not affect the carotid arteries because it's located now after that aortic arch. So after the branches for our carotid arteries. So type B does not typically affect the carotid arteries because the dissection is going to extend downward as it gets worse. So type A has CCA extension, type B does not. Carotid dissections often occurs distal to the carotid bifurcations, often involving distal ICAs at the entrance to the skull. These are usually spontaneous or following some sort of trauma. Sonographic findings, you want to visualize that intimal flap, any flow disturbances, and you may visualize a duplicated lumen. Document the origin and extent of the dissection, presence of direction and characteristics of flow, including velocities, measurements in the true and false lumens, and determine the patency of the ECA and the ICAs. So I'm going to stop at dissection for a little bit. So it's 11 o'clock now. Why don't we take like an hour break, get something to eat, come back at 12. We'll try and finish up at least this PowerPoint. So at least we've knocked off like this, this section. And then I'll let you guys, keep you guys posted. I'll update the outline and repost it onto D2L for you guys. I apologize, man. Does anyone have any questions about the carotid stuff? I know when I took my boards, they loved signs and symptoms of carotid disease. There was lots of questions. They still do. They still ask lots of questions. I asked last year's students when they took their vascular boards. They like to ask lots of questions about patient symptoms and localizing the disease based on the patient's symptoms. So unilateral symptoms, unilateral paresis, unilateral hemiplasia, anterior circulation. And just remember, it's the opposite vessel that's involved. So if it's right-sided symptoms, it's the left ICA or left side of the anterior circulation. With amaurosis fugax, that temporary transient blindness, or what's called the shade pulling down over your eye, it's the same side that's affected. So if I have amaurosis fugax in my right eye, it's going to be my right ICA that's affected because it's due to that temporary occlusion of that right ophthalmic artery. Stop recording. All right, so just finishing up this segment. So we just finished up dissection. Now we're going to move on to carotid pseudoaneurysms. So these are, same thing as our pseudoaneurysms that we learned previously. Carotid pseudoaneurysms are very rare. I mean, I've only ever encountered one of these, in my 10 years of doing vascular scanning. And this was a result of somebody messing up somewhere when they were putting in a line in the woman's neck. And it was bad. This woman, you can imagine, you think you're going into the vein, you're going into the carotid artery, and just what could potentially happen with that. So pseudoaneurysms most often result from violent trauma, percutaneous jugular vein catheterization, or therapeutic or diagnostic arteriography. Other causes could potentially be due to, again, our usual culprits here, those connective tissue disorders, Marfan syndrome, Ehlers-Danlos, the fibromuscular dysplasia, vasculitis, so inflammation of the vessel walls that cause weakening of the wall. Pseudoaneurysms, same like they would be in patient's groin. You can potentially palpate the area and feel a pulsatile mass. Patients will have, neck pain. There could potentially be compression of the nerve causing cranial nerve palsy. You'll also see, in addition to swelling, ecchymosis or bruising in the area. So, every pseudoaneurysm is going to have the same classic characteristics. So you'll have that to and fro, that bidirectional flow pattern that's seen in the neck. The pseudoaneurysm itself, appear as a spherical mass-like lesion, which you see blood flow entering in and swirling around and circulate, and it'll be circulating from the carotid artery. So again, pseudoaneurysms have to be arterial in nature. So if you're Doppling it and you're not getting something that looks like an arterial signal, then it's not a true pseudoaneurysm. Maybe this is just extravasation from a vein that's bleeding. So, there's a hole in that vessel wall, body's encapsulating that bleed, trying to contain it. And that's why you get the blood flow entering into that pseudoaneurysm, swelling around. So another term you can, throw in there is that yin-yang pattern. So you need to have that bidirectional flow pattern seen in the neck. That's your real diagnosis. Consequence of this is potential rupture, and it's considered a life-threatening soft tissue hemorrhage. So with carotid pseudoaneurysms, we don't do the thrombin injection that we would do for a lower extremity pseudoaneurysm. For obvious reasons, like you're so close to the brain. God forbid that thrombin leaves that pseudoaneurysm and you send thrombin into the patient's brain. No way. There's way too much risk involved in that. So these patients need to go for surgery. So this is a surgical repair that has to be performed. The following information should be obtained in order to be attained in the diagnosis of pseudoaneurysm. So you want to document the size and location. So you're going to take your measurements, sagittal, transverse, for the actual pseudoaneurysm itself. Measure, again, the diameter of the neck. Demonstrate the presence of that to and fro or bidirectional flow in the neck. You're going to measure the length and diameter of the neck. And if any portion of that pseudoaneurysm appears thrombosed. So this shouldn't say AVF here. This is still pseudoaneurysm. So here's an example again. We're in transverse now. You can see your common carotid artery, jugular vein, and then the neck leaving the neck of that pseudoaneurysm, leaving the common carotid artery, and the pseudoaneurysm itself, and a portion of it looks like it's partially thrombosed. This part looks like it's still actively bleeding. So if I was to Doppler in this neck, I should get that classic bidirectional flow. The one I saw was much larger than this, and it was like right up to the surface of the skin, like, and this carotid's fairly deep. So I was talking like a carotid here with like a neck and then like a large active pseudoaneurysm with just like a thin layer of skin, like right under the surface of skin. I was like, Jesus Christ. Like this thing, if it ruptured, forget it. Carotid AVF. So these are arterial venous fistulas. Almost always results from trauma, either violent or iatrogenic. So that could be, again, trauma from catheterization, IV insertions, things like that, some sort of penetrating trauma. Clinical presentations include a visible neck, ecchymosis, so that's that bruising, soft tissue fluid, a palpable hematoma, potential pseudoaneurysm, palpable or audible thrill, a dilated and hyperdynamic draining vein. So just think about this now. We've created an arteriovenous fistula. So the terms that we always have to associate with the fistula, it's going to be a palpable or audible thrill. So we should be able to feel that thrill, where that fistula is itself, because we have very turbulent flow. Blood flow is going from the carotid artery into the jugular vein. If we now have a tremendous amount of blood flow now, just going from the carotid artery into that jugular vein, the jugular vein is going to be very distended. And what that means by hyperdynamic is we're going to have very fast or markedly increased velocities within that jugular vein now. It'll technically be mixed signals now. So we'll have what looks like an arterial component in that venous waveform. Treatment for this is going to be surgical or an angiographic procedure like a covered wall stent. So this picture shows actually a very lengthy track connecting a superficial vein with the superficial hematoma and a lot of swelling around it. So this is a thrombosed hematoma, a superficial vein. So blood flow is going from that artery into that superficial vein. And the draining vein shows, very turbulent flow, a very fast velocity. So this doesn't look like a normal venous waveform. So it's very, very chaotic. It's very turbulent. It's markedly elevated. So some non-atherosclerotic lesions that we could potentially see in the carotid arteries. So potentially there could be trauma to the patient's neck that can damage the vessels. Patients could also be suffering from arteritis. So example of that would be Takayasu's arteritis or temporal arteritis. So when you see that ending of itis, just think inflammation. So this is inflammation of the vessel walls. So it's basically all three vessel layer walls. So the intima, medial, and adventitial layers. So that thickening of the vessel walls results in narrowing of the actual patent lumen. And creates a situation where we now have, a stenotic lesion as a result of that vessel wall thickening, that arteritis. So if you think about it, the vessel wall gets thickened, so that open channel where the blood flow can pass through now gets smaller because the walls are much thicker. So again, that other condition that we mentioned before, the FMD, the fibromuscular dysplasia. So this is often referred to as the string of pearls or string of beads appearance on angiography. So this is an abnormal fibrous or muscular tissue development of collagen vascular, of the collagen vascular connective tissue. It's an idiopathic segmental and non-erythematosus disease of the musculature of the arterial walls and leads to stenosis. So if you kind of just think of like a string of pearls, you get an area of dilatation and then a very narrow area that's stenotic, then another area of dilatation, and another area stenotic. So fibromuscular dysplasia most commonly affects the renal arteries, the axillary, iliac, basilar and carotid arteries, as well as the hepatic and some of the intracranial arteries. Two other imaging presentations can be a long tubular ICA stenosis or an asymmetric ICA outpouching. Also important to remember with FMD that it's usually seen in young women ages 25 to 50. So think for fibromuscular dysplasia, young women, string of pearls. It has a string of pearls appearance. And then the vessels that it's associated with, your renal arteries, carotid, hepatic, as well as your intracranial arteries. So fibromuscular dysplasia is the most common presenting symptom in symptomatic hypertension. So this causes, the reason that it causes the hypertension is because it causes renal artery stenosis. So those areas of narrowing that are associated with the FMD cause stenotic lesions, and in turn affect perfusion to the kidneys, creating uncontrolled systemic hypertension. With carotid involvement, these patients have transient cerebral ischemia, or even cerebral hemorrhages are presented. They tend to occur relatively distal to the ICA and usually present at a younger age. So atherosclerosis, we think of patients that are older. FMD, we associate with patients that are younger. Absence of calcified plaque also suggests the diagnosis of FMD as well. So there's no, with fibromuscular dysplasia, there's no associated calcified plaque with this particular disease. These are some possible appearances for patients that would have fibromuscular dysplasia. I'll be perfectly honest, on ultrasound, it's something that's quite difficult to diagnose, particularly when they're worried about it in the renal arteries. And the renal arteries are difficult to image in and of themselves. Trying to diagnose fibromuscular dysplasia with ultrasound is quite challenging. So more often than not, these patients are getting some sort of angiogram to ultimately diagnose FMD, or at least support what you're seeing on ultrasound. So here's an example of carotid fibromuscular dysplasia. You can see kind of looks like a little string of pearls where you get some irregular continuity to the vessel walls. You get a bulging pinching in, a little bulging pinching in. And this causes a moderate disturbance and increased velocities. Another example of FMD. Another topic that's likely to show up on your vascular boards is something called a carotid body tumor. So a normal carotid body is a tiny ovoid structure located between the adventitia of the carotid bifurcation between the external and internal carotid arteries. So this tumor has a low malignant potential. It's called a paraganglioma with a low malignant potential. It's a component of the automatic nervous system that participates in the control of arterial blood gases and pH levels, as well as controlling blood pressure. The carotid body tumor is a highly vascular structure that's fed by the ECA. That's also important to know when diagnosing the carotid body tumor. You can often find a feeding vessel connecting back to the ECA. The most common presentation is a palpable neck mass with headache. Neck pain is the second most common presentation. Treatment is resection and surgical excision of this particular tumor. So the classic images that you see with carotid body tumors, you're going to see a large hypoechoic heterogeneous mass that has internal vascularity to it, sitting between that bifurcation between the ECA and the ICA. So you have ICA running on top, ECA going underneath, and this carotid body tumor sits right in the middle, right in that bifurcation. So here you can see on the angio a better presentation of that tumor. So ECA and ICA, and that carotid body tumor sitting right in that bifurcation. This is a very large carotid body tumor. There you go. So this is a nice picture showing actually that the feeding vessels now coming off that ECA. So here you have your CCA bifurcation into your ICA and ECA. You could tell this is the ECA because you can see some of these branches. So you got your superior thyroid artery for your first branch right there. So you can definitely, say, all right, I'm sure this is ECA. You got this large hypoechoic heterogeneous mass with internal vascularity. You could see a feeding vessel coming off the ECA. So this is, all the information that you can need. The diagnosis is quite clear in this picture that this is a carotid body tumor. I mean, not much else is going to sit right there in that pocket, splitting the ECA and ICA like that. Subclavian steal syndrome. All right. So I mentioned before that the vertebral arteries act as a collateral pathway for circulation, for blood flow, for the upper extremities. So if there are patients that have central arterial occlusions in the subclavian arteries or in the brachiocephalic artery, the vertebral arteries on that particular side where the occlusion is will act as a collateral pathway to provide blood flow out to that extremity. So this condition is called a subclavian steal syndrome. So it's a condition in which the blood destined for the brain is shunted away from the cerebral circulation because the subclavian or innominate has a high-grade stenosis or occlusion proximal to the takeoff of that vertebral artery. So that's an important part of that statement, that end there, that the stenosis or occlusion is proximal. It's before the takeoff of that vertebral artery. So if I have a stenosis or occlusion that's after the takeoff, if it's further down the arm, further down the subclavian artery, no luck. The vertebral artery, it's just going to go about its business. There's no way for that blood flow to be stolen from the vertebral artery to work its way down the arm. So that stenosis has to be proximal to that takeoff. So that's just an important thing to remember when you're trying to, answer these questions and figure out, subclavian steal syndrome and the location of that stenotic lesion. Retrograde vertebral flow, in order to the flow becomes retrograde in the vertebral artery in order to provide blood flow to the arm. These patients are usually actually asymptomatic The way we can diagnose this or, tell that something's up is when we take a blood pressure and notice a difference between blood pressures between the two arms. If we get a difference that's greater than 15 to 20 millimeters of mercury between both arms. So the side that has the lower pressure is the side that has the disease. So that's something also important that you have to remember. So when you take the pressures in both arms and one is significantly lower than the other, the one that has the lower pressure is the one that has the disease in it. So if you kind of just think about it logically, there's something blocking the blood flow from getting down to that brachial when I'm taking the pressure. Of course, my pressure is going to be lower. I have reduced blood flow getting there, and there's not going to be as much pressure there. So the pressures in the affected arm are decreased, or the pulses in the affected arm are decreased as well. So you may not be able to palpate as strong as the pulse in that patient's arm that's affected. God. So this is just a diagram showing a left-sided subclavian steal. We have our aortic arch. Stenotic lesion is going to be, again, proximal or before the takeoff of that artery. So we have to have a stenotic lesion again before the takeoff of these vertebral arteries. So if my stenotic lesion is here, it's not going to affect my vertebral artery flow. We're not going to have a subclavian steal syndrome because the blood flow has nowhere to go at that point. The stenotic lesion has to be here in order to create that draw or that pull for the blood flow. I mean, poor guy, he's going to have, obvious issues in his arm. He's going to have, potentially cyanotic fingers, depending on the degree and level of that blockage, but he's not going to receive that collateral flow due to, from the vertebral arteries. So on the right side, it's a little more complicated just because we have the brachiocephalic in addition to a proximal segment of the subclavian. So with the right side, we just have to take into account what's going on in our right common carotid. So on the left side, we just worry about the left vertebral artery. If we see retrograde flow, and then we know it's left subclavian steal syndrome, and the stenotic lesion is in that proximal subclavian artery. If we're on the right side, though, we have to be able to determine, is the lesion in the proximal subclavian artery, or is it actually in the innominate artery where our occlusion is? So if we see retrograde flow in the vertebral artery and abnormal flow patterns in our common carotid artery, I mean, they could potentially be retrograde. They can potentially be, more post-stenotic waveforms. Then the issue or that lesion is going to be in that innominate artery. If our right common carotid artery has normal flow patterns, they look nice and healthy, nothing, no red flags raised, looks the same as our left side. But we have flow reversal in that vertebral, then we know that stenotic lesion is going to be in that proximal subclavian artery. So proximal to that takeoff. Again, subclavian steal isn't going to happen with lesions that are past the takeoffs of those vertebral arteries. These are just some Doppler waveforms showing some flow reversal associated with subclavian steal. So these are both Doppler tracings from the vertebral artery. So this one is commonly referred to as a crouching bunny sign. So a lot of stenographers said this kind of looks like a little crouching bunny. I don't know. But you see, a large flow reversal here still below the baseline. This is completely below the baseline now. But you also want to be careful too when you're assessing or diagnosing subclavian steel. I practice that I always did, because with carotids, you're constantly shifting your box, changing your angle, inverting, doing lots of things, just to make everything nice and neat. Vessels are going up, they're going down, so it can be a little confusing sometimes, is it really retrograde or did I just invert everything, so I always get my vertebral, don't change anything, switch over to my CCA, and then switch back to my vertebral. If I did my CCA and I knew that that was antigrade, and I switch over to my vertebral now and it's blue and it's retrograde, I know then I have a subclavian steel. But if I'm going back and forth and they're both in the same flow direction and I perceive that CCA to be normal initially, then that's going to be, then I know I just accidentally inverted my color and stuff. So it's always good to double and triple check yourself. So this was just kind of, describing what I was saying before about location of the stenosis, if it's in terms of the right side. So if the right CCA is also retrograde, then that's an anominate stenosis. If the right CCA is antigrade, then it's a right subclavian stenosis. That's proximal to the vertebral. This was a good example too, what the sonographer did, checking himself against the jugular vein now. So he's got a CCA that's showing up blue and a jugular vein that's showing up blue. So we know that, hey, one of these isn't right. So jugular vein isn't going to just all of a sudden reverse flow on us like that. So that's not going to be something that's going to, that's going to typically, that's not something that's going to happen. So here on the right side, this must be a retrograde right CCA. All right, so when we talk about physical examination, again, we got to be familiar with our neurological symptoms. Again, our anterior circulatory symptoms have to do with our carotid arteries. The posterior circulatory systems have to do with the vertebrobasilar system. And then we have those non-localizing symptoms. Things we're also going to assess for, we're going to auscultate, we're going to listen for pulses, bruits, palpate for thrills potentially, look for unequal brachial artery pressures. Excuse me. Do they have you guys taking brachial pressures at the vascular lab? Do they let you guys do that? for them, or not at all? I should at least stop by and make you guys start doing that.
They have us do that at CDC.
Okay. I know in the vascular lab, I always told me that for carotids, they do a bilateral brachial pressure. If it's an abdominal aorta, they just want the one pressure. And the reason for that is they want to, potentially rule out subclavian steel. So they're looking for that difference in pressure. Excuse me. Clinical indications for cerebrovascular ultrasound. So general indications, when there's, an anatomic or physiologic information that would be of diagnostic value. So specific indications for us doing a carotid exam, be a patient who has a TIA or a CVA. Ruling out carotid disease, scratch that. That's not an indication. Just a general rule. If you ever get any orders that just say rule out this, that's not really technically an indication. You're ruling out a disease. You need an indication as like a patient's symptom, like, pain, swelling, tenderness. If you're doing an abdominal study, like nausea, vomiting, right upper quadrant pain, right upper quadrant tenderness, flank pain. So this is an older slide. So rule outs are a thing of the past now. I'll let you know that. But indications for a carotid exam, any of those stroke symptoms that we have, any syncope, collapse, altered mental status, any of those stroke symptoms, any vision disturbances, any dizziness, blurred vision, double vision, Hollenhurst plaque. So that's the small plaques that can break off and travel into the ophthalmic artery. We could potentially be doing a carotid exam as a follow-up after a carotid endarterectomy or some sort of interventional procedure. So carotid endarterectomy is when they actually slice open the carotid artery, open it up, remove the atherosclerotic plaque and a little bit of the vessel wall, and then they close it up, typically with like a little bit of a patch, and sew it back up. Sometimes we also, another indication is we'll assess the carotid arteries. I know this was big in my two hospitals for patients that were pre-op for cardiac surgery, particularly coronary bypass surgery. They wanted us to do carotid artery exams because oftentimes patients who have coronary artery disease, so atherosclerotic plaque in the vessels of the heart, will often have carotid artery disease. So they may, elect to do both at the same time. They may have to do one more prior to the other. So if a patient has significant coronary carotid artery disease, so if they have high-grade stenosis and poor perfusion to the brain, it makes that coronary artery surgery much more difficult and much more risky because they're going to have to be going on a bypass machine. And it raises the likelihood of them potentially having a stroke while they're on that bypass machine. So high-grade stenosis will actually, postpone their surgery for the heart until they can address the issue with the carotid arteries. Known contralateral carotid occlusion. So if we know this patient has an occlusion, we could potentially be doing an ultrasound. If we hear a bruit, so some preventative steps for preventing carotid artery disease. The main thing is going to be stop smoking. Smoking is a huge, huge, huge risk factor when it comes to carotid artery disease. I do ultrasounds for patients who are longtime smokers. Their carotid arteries are a mess. They're so calcified. There's so much plaque buildup in them, and it's obvious the difference between those smokers and non-smokers. It really is. Also, lowering the amount of cholesterol in your diet will help reduce that buildup of those lipoproteins. Exercise. We can always put patients on various medical treatments. Obviously, you want to control their blood pressure, cholesterol, and diabetes. So those are your big three. If you can keep these three under control, that'll go a long way to preventing carotid artery disease. Patients can also take antiplatelet drugs like baby aspirin, Plavix, anti-inflammatory drugs like aspirin as well. We could potentially prescribe vasodilators like Percentin. And then there's also antithrombotic or anticoagulation medications. So again, that TPA is that thrombolytic agent that we can give during the first 3 hours of a patient's onset of patient's symptoms with stroke. Heparin, warfarin, Coumadin, Lovenox, those are anticoagulants. Then there's a couple surgical interventions that we can do to deal with a patient with carotid artery disease. So the first is called a carotid endarterectomy. So I kind of always thought of this kind of like as a roto-rooter job. So you got a clogged pipe, they're going to go in there, they're going to scrape out all that plaque, remove a portion of that intimal lining of the arterial lumen. During the procedure, a shunt is used to divert the carotid flow around the stenotic area to avoid neurological deficit. It's usually performed inpatient. These patients are usually asymptomatic, but have to have a greater than 80% stenosis, or a contralateral occlusion may be present. Symptomatic patients, this procedure will be performed with grades stenosis of 70% or greater, or it could potentially be done with patients with previous TIAs or CVAs. So if you have a history of stroke or transient ischemic attacks, and you have a level of stenosis, you have a high propensity of potentially having embolic strokes as a result of that plaque breaking up, they'll go in there and try and clear it out. If you're asymptomatic, they'll wait till it gets to be a high grade, a really high grade stenosis. It's just showing the procedure, how they surgically open up the carotid artery, remove the atherosclerotic plaque, portion of the lumen, and sew back up. So that's also why it's important when you're doing your visual assessment to look for any scars on the patient's neck, any telltale signs or indications that they may have had an endarterectomy. This is just showing that sometimes they actually use a patch. If the artery is too small, the surgeons may insert a patch as part of the closure. And you can tell on ultrasound if there's a patch by this irregular striations. So parts of the suture and patch material are more prominent in the acute period after surgery. So for me, when I would go up to the OR for these carotid endarterectomies, basically your role is to just, you're not actually putting the probe to the patient for this. So it's the vascular surgeon that's doing it. You're just basically operating the machine. You're acquiring several images. Typically you're gonna have they're gonna be post-op. So you're gonna come up like towards that tail end of the surgery after he's, removed the plaque and sewn up the patient. And you're going to just take those images showing, that the carotid artery is now patent. There's no more stenosis. And you're going to just measure some velocities in the CCA and the bulb and the ICA. So there's a condition called intimal hyperplasia. So this is a thickening of the tunica intima as a complication of a reconstruction procedure or endarterectomy. So intimal hyperplasia is a universal response of the vessel to injury and is an important reason of late bypass graft failure, particularly in vein and synthetic vascular grafts. So basically, you're getting hyperplasia or thickening of that intimal layer as a result of trauma to that vessel. So just think of any healing process involves some degree of swelling. So this vessel just went through trauma. So the natural response of that body is going to be inflammation and swelling. So this shows up in the months after surgery. So you can see it in this case. This was about a year post-op after an endarterectomy. So this shows up in the months after the surgery. The patient develops this swelling of that intimal layer as a result of the trauma, and that now creates. It looks like this vessel has now become refilled with plaque. So this could be like some sort of like homogeneous soft plaque. But to know this patient's history that, hey, they had an endarterectomy in this area, to redevelop plaque that quickly in 1 year, that significantly is highly unlikely. And the more likely diagnosis is going to be this neo-intimal hyperplasia. So basically what happens is there's trauma to this vessel. The intimal layer becomes thickened as a result of that trauma. The natural response of the body is that inflammation and swelling, and it becomes abnormally thickened and remains that way and can be seen up to a year post-op. Carotid stent. So this is a therapeutic alternative to endarterectomy for significant carotid stenosis. Some complications for stent include dissection and potential distal cerebral embolization. So with this, instead of going in, cutting open that artery and removing the plaque, we're now just inserting a stent to try and balloon open and open up that vessel to allow for blood flow to pass through easier. So we'll place the stent in the area of narrowing of stenosis. But some complications for that could be potentially disrupting that plaque and causing a distal cerebral embolism, so causing a piece of that plaque to travel where we don't want it to go. Evaluation for patient for carotid stenting should include plaque morphology. So we want to get a good idea of what type of plaque that is. If this is, ulcerated plaque that, runs a higher propensity or risk for embolization, we may not necessarily want to go down this stent road. But if it's a plaque that's less likely to break off and embolize, then a stent might be a better option. We also want to take into account vessel anatomy. So if a vessel is very tortuous and twisted, maybe a stent's not the best option. It might be difficult to place. We also, if the disease is very extensive and located, in multiple areas, a stent might not also be the most effective choice. This is just showing what the stenotic lesion looked like, and then the insertion of the stent and opening the stent, pressing that plaque along the vessel wall and opening up the channel, allowing for more perfusion of blood. Carotid stent with protective devices. ICA stenting with the balloon embolic protection, you see here in B. C, you see the balloon occlusive device eliminating flow. So they inflate this balloon higher up to try and make sure that none of the plaque gets, when they're inflating that stent or opening the stent, gets pushed up. The flow device permits flow from trapping emboli and probably is a better choice. This is a flow filter. These are a couple of options now that they have to try and prevent embolic events with putting in a stent. It's just some pictures showing some stents that are used in practice. So stents are very obvious when you see them. You can see the linear echogenic striations of the stent. You can see as well where the stent begins on either side here. Here you can actually see the mesh portion of that stent as well. Again, so you know exactly where that stent begins. So when you're assessing any stent, you always want a Doppler proximal before the stent, proximal segment of the stent, mid and distal stent, and then right after the stent. Getting in the home stretch. So carotid bypass grafts. So in addition to stenting, we can also potentially do a bypass graft as well. These aren't particularly common, but it is an option. So patient can have bypass or reconstructive procedures where endarterectomies may be inappropriate. Grafts may be synthetic or use an autogenous vein of origin. This is an example. If a patient had a potential stenotic lesion in, the proximal left common carotid, they can do a stenting blood from the left subclavian above that level of that stenosis, and allow for perfusion back up to the brain. So this is a carotid-subclavian graft here. So in this one, they're actually showing blood flow coming up the right common carotid. And in this stent, the flow direction is actually being directed around this stenotic lesion in the proximal subclavian. So this is to prevent the need for the arm to steal the blood from the vertebral. So in this case, we now created a stent where we're just siphoning off a little bit of that blood coming up the carotid, putting it back into the subclavian to allow for perfusion to the arm as well as the right vertebral artery. This is a carotid stent. As the name implies, it goes from carotid artery to carotid artery. So these stents can be a little bit challenging because you have to determine which is the inflow and outflow. Is the blood flow going from right to left or left to right? Then there's something called an interposition graft. So this is usually performed when a carotid aneurysm is present, or the CCA disease is so extensive that replacement or exclusion or excision has been indicated. This is usually an end-to-end anastomosis of a vein section between the native CCA and the distal ICA. ECA can be implanted into the graft or even excluded. Sonographic appearance is usually that of a normal carotid bifurcation or of one continuous vessel from base to mandible. That looks pretty gnarly. So this is a reconstitution using branched GSV interposition between the CCA and ICA. Looks like they're referring to this segment of vessel here. All right, so I just want to go over the one last slide, just a short one. 24, just with the carotid examination. So for our carotid examination, I mean, there's three components to all of our carotid examinations, and they're all equally important. So we need a good grayscale exam. We need a good color Doppler exam, so showing good color filling. And we need a good Doppler exam, getting good accurate Doppler measurements. So typically, most carotid exams, you're going to begin in your transverse plane. So you'll start with a transverse sweep or transverse assessment, starting proximal as low down as you can go of the common carotid artery. If you're able to see the origin of the common carotid artery, that's fantastic. If you can't, you're not going to be able to on every patient, but try and go as low as you can. And I like to just start, in 2D, just get nice grayscale, crisp grayscale images and just slowly working your way up from that proximal CCA all the way up to that bifurcation. So you're assessing the common carotid artery all the way up in grayscale. And you'll be able to look for any signs of plaque, any stenotic lesions as you work your way up towards that bifurcation. Some techs will do just grayscale first, and then come back down and repeat the process with their color box on, getting nice color images, nice color filling. Make sure you don't have too much gain where you're bleeding out. Make sure your scale is set properly. Some people will do it as they go. So they'll just do proximal 2D color, work up to the next segment, mid CCA, 2D color, distal CCA, 2D color, bulb, 2D color, bifurcation, 2D color. Once you've completed your transverse assessment, then I'd switch to a longitudinal plane. And you're going to do the same thing now, but you're going to be repeating with grayscale, color, and now this time you're going to include Doppler assessment as well. So this is just a transverse view. So I know that some of your DMS ladies are going to start thyroid scanning if you haven't started thyroid yet. So this is your thyroid gland over here. So this just gives you a little relational anatomy. So some of the slides before we said that the common carotid artery was located posterolateral. So if we have a transverse view, this is going to be the right CCA. So this is a little bit posterior and lateral to the thyroid. And we see our jugular vein more anterior. These are some nice pictures, just showing, your presentation, your common carotid, jugular vein. So this is a nice image for this patient. We actually can see a nominate artery, CCA, subclavian artery. So we're gonna, again, work our way up in transverse, just imaging the common carotid in its entirety, proximal, mid, distal. Then we're gonna take a dedicated bulb picture. So as you're sliding up that carotid artery, you're gonna notice, it's gonna stay pretty uniform in diameter. And then you're gonna get to a point where that carotid artery is gonna start to dilate a little bit. So this will become a little bit ovoid. It's gonna start getting a little bit larger. If you keep sliding up, it'll eventually bifurcate. So the carotid artery then split into the two vessels. And that'll be, you've gone too far. You'll be in your bifurcation at that point. So you just slide back down a little bit where it's still one vessel. And that would be your point where you're at the bulb. So again, you're going to do in transverse, color. And then this is just showing the bifurcation now in grayscale between your ECA and ICA. So at this point, the CTA is split. So I'm pretty safe to assume that I'm still on the right side here, just kind of based on the way that they're splitting. ICA is going more posterior, ECA is going more anterior towards the patient's face. If I'm just kind of picturing how the patient's head is turned and I'm lying, I'm scanning, this is kind of more going towards his face. This is more going towards his jaw. You can also look at the vessel diameter size too. Again, ICA is typically larger than the ECA. This is just showing the sequence now, a transverse sweep with color on. So this isn't a very good picture. So I don't know if this is actual plaque here in the bulb or is just my gain too low. Or is it an issue with the scale? I've seen a lot of sonographers when they get to the bulb, they actually switch to power Doppler just to ensure that, you know, they get adequate and like true filling of that bulb area. Because sometimes, you know, especially depending if the patient has poor cardiac output, if it's a little old elderly lady who's got a weak heart and it's got very slow blood flow, once you get into the bulb, velocities may drop quite substantially. And what may look like plaque may just be slow flow that we're not picking up. So just be cognizant and careful. You know, what you're showing the doctor is really true. And then this is a picture here showing bifurcation for ICA and ECA. I'll give a point to anyone who can guess what this is. Point on your final. I want to see.
Is that the vertebral?
Nope.
Is that the first branch of the ECA?
Which is?
The superior thyroid?
Oh, there you go. Got your sonography hat on. Good. Yeah, so that's probably that first branch for off that ECA. Yep. So we're right at that bifurcation. And right near that bifurcation is going to be the first branch off the ECA. So if I turn in long, I could probably connect that back to there. Good. There you go. Vertebral is going to be more posterior. So we actually have to change our scan window to visualize vertebral with ICA. So it's just, when we get in the lab, it's going to be a real angle. You're going to be tilting back. Like, how far back do I have to get this vertebral? Oh, there it is. It's quite an angle back. So after we've done transverse assessment, we're going to do longitudinal assessment. I know it seems a little like, you know, like we've gone down and come back, gone down, come back. Now we got to go down and come back again. Some labs I've seen people do all three in one segment. You know, they just do proximal, transverse, sagittal, color, and then just move on. It all depends, you know, on the protocol that your particular facility likes to do. I know Christiana likes to do a transverse assessment. Riddle likes to start with transverse and then go back to long sagittal. So again, it just depends where you are. Just ensuring that, you know, you get all your images that you need. So imaging the CCA isn't terrible, tracking it up. It's when we get into this bifurcation is where you people tend to struggle early on, being able to image and differentiate ECA, ICA, just getting the feel of opening up ECA and ICA. So this is what we're going to spend the majority of our time, you know, practicing on, you know, this distal CCA bulb and bifurcation, and then being able to eventually just track ICA as far as we can go. In terms of assessment, we really only assess the proximal ECA. We only Doppler velocities in the proximal ECA, because again, the area of stenosis or blockages are going to be in these this is going to be your area, your zone where you're going to get your plaque development. And really, there's not much that they do for, you know, a stenotic ECA or an occluded ECA. So they're not going to, you know, do an endarterectomy to open up a person's ECA. So we just have to be cognizant that every person's different. We're not always going to see this nice tuning fork picture, you know, nice fork. oftentimes we're just going to be able to see one vessel at a time. I know that I'm like this. So for me, you're only going to be able to see CCA bulb ICA and then CCA bulb ECA, like your CCA ECA. You're not going to be able to see, this nice fork. So you'd only see, basically something that looked like that. Like if I was to cut off that ICA. So you're only going to see one of my vessels at a time. And for me, it's more of an angle back and forth. So again, with color assessment, we just want to make sure we're optimizing our image, make sure we're steering our box in the correct direction. So again, just a good rule of thumb, I look at which bottom corner that vessel is running towards. So this vessel is running towards this bottom corner. If the vessel is going this way across the screen, it'd be running towards this bottom corner. I would steer my box the opposite direction towards that bottom corner. So in this example, the vessel is going towards this bottom corner. I'm going to steer my box or angle my box towards that bottom corner. And then when we're Dopplering, this is where angle becomes very important now. So we're going to try and maintain a 60-degree angle at all times if possible. If we need to go under 60 degrees, that's still an option, but we try and maintain 60 degrees whenever possible. We just want to ensure we're not going over 60 degrees with our Doppler angle. So with carotids, it's a lot of heel toeing to try and manipulate the angles, a lot of fine-tune adjustments. So a lot of the ultrasound machines now have fine-tune adjustments that make it a lot easier to maintain that 60-degree angle. And then our measurements are going to be our peak systolic and end diastolic numbers. So again, you just want to be careful that you're not showing plaque that really isn't there. So you want to just optimize your color and your gain to ensure that, hey, this plaque is really real. So we Dopplered proximal for CCA, we Dopplered proximal, mid, and distal. We typically get a 2D in color image for the CCA bulb and ICA, just showing flow through. Most labs typically don't Doppler the bulb, just because you'll get kind of an erratic flow pattern in the bulb. So I'll show you guys in a minute, what that looks like. And then when you continue Dopplering, you'll Doppler proximal ECA and then proximal ICA. And for the remainder of the exam, you have to Doppler for, in the clinical setting, proximal, mid, and distal ICAs. This is just showing the CCA bulb ECA. And then Dopplering the right ECA. So this is a picture showing vertebral artery. So you can actually see vertebral vein running anterior. There's also a second vertebral vein that we're getting a little piece of it running posterior to the vertebral artery there. You don't always see the veins. Some patients you do, some patients you don't. But you can see the bony processes that the artery and veins are passing through. Get that shadowing on either side. And you see a small segment of the artery. So you just place your color and you Doppler between. The main thing with the vertebral arteries is just showing the overall characteristics of the waveform. Is it a nice, normal, low resistant waveform? Is there any evidence, of post-stenotic tardus parvis waveform? Is there any evidence that there could be a a more distal occlusion? So is it all of a sudden now a high resistant waveform? Is something blocking that blood flow higher up that we're not seeing? So we're getting a high resistant waveform. So it's more about the characteristics than the velocities. And then more importantly than the characteristics is the direction. So is the vertebral artery antegrade or retrograde? So every carotid Doppler preliminary report you're going to write, you're going to specify whether the vertebral artery is antegrade or retrograde. So then just interpretation. So when we're interpreting our carotid reports, we're going to document any areas of wall thickening, any areas of plaque formation, atherosclerotic plaque formation. We're going to try and characterize the plaque, whether it's heterogeneous, homogeneous, echogenic, calcific. Does it look calcified? We're going to try, characterize the location and the extent of it. So there's two ways. There's two things that you also have to be cognizant of with carotid plaque when we're talking about extent versus severity. So extent, I think, how far does it extend? Like how long is that segment of plaque, or how long is that stenosis? So in order to determine how long something is, you have to turn in sagittal. You have to be in the sagittal plane to that to be able to see how long it is. The severity or degree of stenosis, how thick, or how much of that lumen is narrow, then you have to be in a transverse plane. So turning in transverse will tell you the severity or degree of diameter stenosis. The extent, how far does it extend? You have to be in a sagittal plane. So we're going to utilize color flow to locate areas of stenosis. We're going to look for areas of turbulent flow. We're going to utilize color flow to help us track the vessel course, as well as determine flow direction and recognize any abnormal flow patterns. Remember to always use power Doppler if you're ever questioning occlusion versus trickle flow or severe stenosis. And then with our spectral Doppler analysis, we want to try and maintain Doppler angles of 60 degrees or less and use a small sample volume. We're only sampling at the middle, or those central velocities in the middle of the vessel. We're going to assess for normal bilateral symmetric waveforms. So what we see on the right should match what we see on the left, level for level. So our proximal CTA should look pretty similar, mid CCAs, distal CTAs, ICAs should all look pretty similar from one side to the other. So then we're going to try and also determine if our waveform that we're getting, if the site that we're sampling, is this a pre-stenotic zone? Are we in a stenosis? Is this the stenotic area? Or is this a post-stenotic zone? So again, a post-stenotic tardus parvis waveform. So if we're getting tardus parvis waveform, we're post-stenotic. We're sampling after a stenotic lesion. Since we're talking about cerebral vascular blood flow, it should be nice low resistance. If we see something that is high resistance, or for example, we don't see any diastolic flow at all, just a systolic bump, then we know something is blocking that blood flow from getting to the brain. So that means we're in a pre-stenotic zone. We're going to measure peak systolic velocities and diastolic velocities, and we're also going to calculate velocity ratios. So then we're going to talk about our Doppler criteria. So the consensus committee on ICA stenosis criteria. Doppler wave, so exams should be performed again by a credentialed vascular technologist. They should all include grayscale, color, Doppler, and spectral. Doppler waveform should be measured with an incident angle as close to 60 degrees as possible, but not exceeding 60. And volume should be placed within an area of the maximal stenosis. It's recommended to establish protocols for stratifying the degree of ICA stenosis based on these Doppler measurements. And it's also recommended not to subcategorize stenosis that's less than 50%. So when you're imaging or you're writing up your preliminary reports, a normal ICA or normal exam would be a patient that has no plaque, nothing at all. You know, their carotids are clean as a whistle. As soon as you have a little bit of plaque, even if it's very, very insignificant, it would be considered a less than 50% stenosis. So it's not recommended to be like, oh, you know, that's only a 5% or 10%. They don't want you going down that road. It's not recommended radiologists go down that road and categorize stenosis, you know, subcategorize stenosis that are less than 50%. It's just normal is nothing, less than 50%. 50 to 69% is the next category, and then greater than 70. It's recommended that the ICA peak systolic velocity and the presence of plaque on grayscale and color Doppler imaging should be the primary parameters used to diagnose and grade ICA stenosis. And then that the ICA, CCA peak systolic velocity ratios, as well as the end diastolic velocities, can also be used as an internal check. So you can use some of these other values to kind of, you know, double and triple check yourself. Like, all right, this is the peak systolic velocity I'm measuring, you know, but, you know, this end diastolic velocity doesn't make much sense. It's not really jiving with what I'm getting for peak systolic, or my systolic peak systolic velocity ratio doesn't really correlate with what I'm getting. You know, that might be an indication. Maybe you should go back, remeasure, maybe your angles are off a little bit. So this is the chart that I grew up with that was posted on every vascular lab that I worked at. I was told that the numbers changed, and I went to Intersocietal's website, and they did make recommendations at the end of last year to change these values up. So I reached out to my friends at one of the hospitals I work at, and that was news to them. They didn't realize any changes had been made, and they are an ICAVL or accredited vascular lab. And they just went through getting their certification a couple of weeks ago using these values and numbers. Wednesday, I have Dr. Pellerito, who works at the other hospital, who wrote our vascular textbook, coming on to speak to us, or actually to, to the second years. And I'm going to ask him, you know, what velocities he uses. And I put in an email or request to ARDMS to see if they changed their numbers that they used. Basically, the change involves the peak systolic velocities for normal and less than 50% over here on this side. And they increase these numbers to 180 centimeters per second. So 50% stenosis doesn't begin until 180 centimeters per second. Everything else remained the same. But I just want to see, you know, if ARDMS is using this chart, or if, you know, it's common practice. Who was it that brought me this new chart? It was one of you guys. No one's taking credit. Maybe it was a second-year student. Someone came to me with the chart. They're like, these are the new numbers that we use at a vascular lab. Maybe it was Elena in Bay Health. Maybe. I have to double check. I mean, someone just came to me, and that's why last week I was like, I started emailing ARDMS. I'm like, wait a minute, these numbers change. Holy moly, they did change, or they made recommendations to change it. So whether these recommendations have been implemented yet by hospitals, I don't know. Doctors don't like to change their ways. I know that much. But anyway, so I'm going to go with these for us for now. So these are the numbers that I know until ARDMS tells me no, we're going with these new numbers, but I don't foresee that, seeing these changes just, came out at the end of 2021. So again, these are the numbers that, you really have to start to commit to memory. Really 125 and 230 for peak systolic velocities. So under 125 is considered normal. Again, like I said, as soon as that patient has a little bit of plaque, it's considered a less than 50% stenosis. The velocity should still be under 125. It's when you get over 125, then it can be graded as a 50 to 69% stenosis. So peak systolic velocities of 125 to 230 falls under that 50 to 69% stenosis. And then velocities over 230 are considered greater than 70% stenosis. So that's considered a high grade stenosis. So again, we don't really, try and break it down any further than those, 4 criteria: normal, no plaque, a little bit of plaque, less than 50, 50 to 69% or greater than 70. In terms of end diastolic velocities, it's also pretty simple. So normal and less than 50, your end diastolic velocities are going to be less than 40. For 50 to 69 is 40 to 100. And greater than 70 is greater than 100 for your end diastolic velocity. So that's why I said you can sometimes use some of these other criteria to kind of double check what you're getting here. So if I got a peak systolic velocity of 235 and my end diastolic velocity was 35, I might go back and maybe my angle was way off. Maybe I was I was actually over 60 or something like that. Or I wasn't Dopplering quite right. My angle just didn't align right. There was an issue. I would go back and remeasure, or vice versa. If this was really low and this was really high, or if I used my velocity ratios. So these velocity ratios are used to determine, they compare the distal CCA to the proximal ICA to show how fast the blood is, accelerating between those two segments. So again, most of our stenotic lesions are going to be in that bulb bifurcation area. So I'm going to get, my velocity in the CCA, say it's 100. My velocity in the ICA is now 300. So that would be, a 3. I mean, I'm just using numbers. So ICA was 300, 100. So 3 over 1 would be 3. So that would fall in this range. So that's how this velocity ratio works. So sometimes this velocity ratio can be actually quite useful in patients that have very poor cardiac output or a very weak heart. So, you got a 99-year-old lady who his heart's barely beating, it's barely pumping blood. Her velocities, and her CCA are 20 or something like that. And then all of a sudden it jumps up to 100, in the ICA. That's a 5-fold increase. And you could see there's plaque and just it looks really stenotic, but you're not getting a fast velocity because she's got a weak heart and poor cardiac output. So then that's a good example of when, you could potentially use your ratio over these other things, to determine level of stenosis. So you do your visual estimate, you'd look at it and yes, I definitely see plaque there. I see this vessel narrowing. I have a nice transverse picture showing, plaque all around, a little patent lumen, a little bit of blood flow getting through. And this is what I'm measuring for the velocities, and I'm getting a 5-fold increase. So I would definitely fall into that, greater than 70% stenosis. You guys are gonna love carotids, trust me. That was a lot. I apologize. Does anyone have any questions about any of this stuff before we go? I'll let you guys know during the week, like, you know, what my status is. Hopefully I can get back into the Riverside sooner than later, and maybe next week we'll just double up on lab, just do a lab day scanning carotids. Oh, God. Just do like kind of like a morning and then an afternoon group. Hello. Does anyone have their camera on? I don't think so. Nobody. It's kind of funny. Like I sit here sometimes, I just kind of scroll up and down, like staring at the boxes. I don't know if anyone was at Wilmington today, but they're on edge. They got their middle states evaluation and or not evaluation, accreditation. So the college is going through their own accreditation right now. The deans are all frantic. 125, 230, 40, and 100. Those are your magic numbers. Then for the ratios, 2 and 4. Well, you guys are good to go. Free to go. If you need anything, just email me.
Hope you feel better.
Thank
Feel
you guys. I appreciate it.
Yeah, thank you. Feel better.
Thank you.
Thanks, bye.
All right.